Hello and welcome everyone to ZaranTech.
Did you know that 68% of healthcare organizations are adopting Agile methodologies to enhance their operational efficiency and patient care? That's a significant leap forward in improving how healthcare services are delivered. We're excited to dive into Agile Business Analysis in the healthcare domain. Agile Business Analysis, specifically tailored for the healthcare sector. Agile methodologies focus on iterative development and flexibility, which can greatly benefit healthcare organizations by making processes more adaptable and efficient. Agile practices are more than a trend. They're proven to boost project success by 42% and cut costs by 29% in healthcare, leading to better patient outcomes and efficient resource use. Agile's impact on healthcare is significant. It helps providers adapt swiftly, improve patient care, and streamline operations. This flexibility is vital for responding to new challenges effectively. We'll cover core Agile principles, key practices, and their specific applications in healthcare settings. You'll gain insights into how Agile can be a game changer for healthcare analysis and project management. Before we begin, please make sure you subscribe to our YouTube channel and hit the bell icon for regular updates from us. Now let us take a look at the agenda. Agenda 1. Overview of health organization. 2. Health claim process. 3. Healthcare domain BAs. 4. Healthcare domain claim process. 5. Healthcare claims process EDI transaction. 6. Managed transaction. 7. GE and GS functional group. Let's dive in.
Started with understanding what is health insurance. We understood that health insurance is a contract between two parties, one being the insurance company and second one being the member or the insured. And as per the contract, the insurance company need to cover the risk associated with the healthcare costs that the insured may run into. And in return, the insured is supposed to pay some fixed dollar amount as premium, right? And we understood few key terms associated with healthcare. We understood that anyone who provides a health-related service is called as provider, and anyone who pays for the service is called as a payer. So insurance company obviously would be the payer in most of the cases, and anyone who provides the health service, meaning a healthcare provider like a hospital or a clinic or a chiropractor or a lab or a pharmacy, anyone who provides a service is called as a provider. The insured is called as a member, meaning anyone who is getting benefits from the insurance company or who is getting benefited through a health insurance plan is called as a member, and the person who holds the subscription to health insurance plan is called as a subscriber. And lastly, we also discussed a term called as purchaser. A purchaser is somebody who purchases the plan or who pays for the premium associated with the health plan. Few terms associated with the cost, and we understood that premium is a fixed dollar amount that an insured should pay to the insurance company for covering his risk. And we discussed that copay is a fixed dollar amount associated with the service that the member has to pay out of his own pocket whenever he gets that service. Coinsurance is a fixed percentage of the out-of-pocket expenses that the member should bear out of his or own pocket when he gets some service from the healthcare provider. And finally, we discussed that deductible is a fixed dollar amount that the member should bear out of his or her own pocket before he is entitled to get the benefits from his health insurance plan. We discussed the reimbursement models, and we understood that there are two different types of reimbursement models. First one being the fee-for-service model, where every single service is accounted for independently and charged appropriately at a service level. And capitation model is a model where insurance company would be paying a fixed capitation fees to the provider in return for covering the services or any covering most of the services uh, mm, associated with the members. So we understood that fee-for-service model is the most prominent model and capitation model is the less prominent or very rarely used model. Two different terms, first one being the cost shifting. Cost shifting is a concept where healthcare providers would be charging more to uninsured customers because they want to cover the losses that they might have accumulated by providing discounts to insured customers. And the second and very important term is coordination of benefits. What is coordination of benefits? Coordination of benefits is a concept through which the member can get benefited from all the health insurance plans or all the plans where he holds the membership, provided that the total amount that he is getting reimbursed doesn't exceed the 100% of the cost that he might have incurred on his healthcare. So now let's move on to our next concept. So the next concept is understanding health plans. Okay, so primarily we can categorize our health plans into two different categories. What is the first one? First one is private health plans, and the second set would be government supported health plans. And as the name suggests, private health plans are the health plans that are managed and administered by private parties. Like example would be Cigna, Aetna, or United Healthcare, Anthem. So there are many insurance companies or health insurance companies that provide health insurance. So going back to what we were discussing earlier, private health plans, and as the name suggests, these are the plans that are managed and administered by private health insurance companies like Cigna or Aetna or Anthem, United Healthcare, all these companies. And the second group is called as government supported health plans. We'll get to that a bit later, but just to give you a brief idea, government supported health plans are the plans that are managed and administered by government parties, okay, whether it is state government or federal government or uh, military or federal government forums. So there are multiple groups belonging to governments that would administer different types of health plans. Okay, they are categorized as government-supported health plans. So to start with private health plans, again, private health plans can be broadly classified into two different categories. What are these two different categories? The first type is called as fee-for-service or indemnity plans. Okay, so I should correct this slide. Indemnity plan is the most popular name for this type of plans, and they can also be called as fee-for-service plans. So what are indemnity plans? Before I explain the difference between indemnity plans and managed care plans, I should explain you some concept. Okay, so let me do that first. So when you pick a health plan, okay, so what might be the type of health plans you might be choosing? You might be choosing a government-supported plan, or you might be choosing a private health plan. So what are the major attributes a member would be looking at when he tries to choose a plan? So the first thing is choice associated with the service. Okay, so our liberty he might be having in terms of picking up a provider. Okay, so if you have more choice, that is the most preferred option, right? So the second attribute one might be looking at when he picks up a health plan or when he tries to choose a health plan is out-of-pocket expenses, right? So when I say out-of-pocket expenses, I'm referring to both the expenses one might incur when he tries to get his service or the premiums associated with the plan. So both of them. So that would be the second factor. And when you think logically, if you have a lot of choice associated with the service you want to get. Okay, meaning if a plan says, okay, you can go to any hospital and you can get any service you want, and you don't need referrals and you don't have to get prior authorization, there is a lot of choice for you, or there is a lot of uh, scope for picking a provider, okay, of your choice. Then obviously that gives a lot of leverage to the insured, but at the same time, that means obviously you will have to pay more out of your own pocket. Why so? Because when insurance companies give you a little choice, and when they say you can only go to this particular provider, or you can only go to this particular list of providers, usually we'll call them as provider networks. So if they are restricting you from any other provider except for list of providers they suggest, then provider will have a lot of control over those. Sorry, payer will have a lot of control over those group of providers, right? So they would be able to negotiate contracts with these providers, and they would be able to negotiate discounts because they are creating these networks, and they are negotiating discounts with the providers, and they are creating networks based on their liberty with this providers, right? So obviously in that case, as a insured, you might be having less choice, or you might be able to pick your preferred provider only from the small group, but still you would get services at a better price, right? So if there is a lot of choice, obviously there will be a lot of out-of-pocket expenses the insured might have to incur. And if there is less choice, that means there is less out-of-pocket expenses also. Okay, so you should understand that. So when we talk about indemnity plans or fee-for-service plans, they are plans with very good choice from member's perspective. So member would have a choice of picking up a particular provider. So member can go to most of the providers of his choice, and member can get most of the services that he might want to get. So obviously, as the choice is more, the out-of-pocket expenses will also be high. So indemnity plans or fee-for-service plans are the plans where member will have a lot of choice, and at the same time, the out-of-pocket expenses will also be very high. And due to that reason, indemnity plans are less popular. Okay, or fee-for-service plans are less popular. However, there is a second group of private supported health plans which are very popular in the country. So what are they? They are called as managed care plans. Why are they why are they called managed care plans? They are called managed care plans because the payer in this case is able to restrict the availability of the service and choice of the provider. Okay, so as the payer is managing the care that a member or insured would be getting, these plans are called as managed care plans. Is it making sense? Good. So again, there are different types of managed care plans. Again, so if I have to classify the managed care plans, we can broadly classify the managed care plans into 4 different types. Okay, what are they? The first type is called as HMO, or Health Maintenance Organization, and the second one is called as PPO, or Preferred Provider Organization, and the third type is called as Point of Service, or POS plan, and the fourth category is called as Consumer Directed Health Plan, or CDHPs. Okay, so what are the 4 different types of managed care plans? The first one is called as HMO, second one is called as PPO, third one is called as POS, and fourth type is called as CDHP. CDHP is not one single managed care plan, but there are multiple types of plans which are broadly categorized together or grouped together into one sector called as consumer directed health plans. Okay, so we'll get into details of each one of them. So what is a HMO or a health maintenance organization? Okay, HMO or health maintenance organization is a type of provider or a type of health plan where provider is very closely associated with the insurance company. And when I say very closely associated, most of the times the provider would be providing explicit or exclusive services to the plan members. Meaning, if we talk about uh, Cigna's HMO, for example, the HMO will not be treating any other type of members from any other plans or they would not be treating anyone except for Cigna HMO plan members. Is it making sense? So the when we talk about the HMO or health maintenance organization, the first and foremost characteristic of a HMO is that HMO will be providing explicit services to the payers plan members. Understood? And the second important characteristic associated with HMO is that every member of a HMO plan will have to register himself with a primary care physician. So who is a primary care physician? Primary care physician or a PCP is the physician who would act as first point of contact for all the health related services associated with the member. Okay, so if you are a HMO plan member, you should mandatorily pick a primary care physician. And if the member needs any specialized services, he can't go to a specialist. Member cannot go to a specialist directly. He should still visit the primary care physician, and the primary care physician would be able to provide referral, or he would be reviewing the case. And if he thinks that it is appropriate to visit a specialist, then he would provide a referral using which the member would be able to reach out to a specialist for getting specialty services. Pfizer has a HMO in California. Okay, but again, most of the insurance companies have their own HMOs. Cigna has a very big HMO in Phoenix, Arizona, and I think Aetna has a HMO in Connecticut area. So most of the large insurance companies, they will have their own HMOs. And again, a member cannot visit out of network provider if he is a HMO plan member. Okay, so there is no way a member can go to a out of network provider. So he can only go to a in network or HMO based provider, and member should also pick a primary care physician, and member cannot go to a specialist directly, and he would need a referral from his PCP. Okay, so that being said, there are four different types of HMOs. Okay, what are these four different types of HMOs? The first type is called as staff model HMO. Okay, so what is a staff model HMO? A staff model HMO is a type of HMO where the provider or the multi-specialty hospital where the services are provided would be running in the premises that are owned by the insurance company itself. Okay, so the facility would be directly owned by the insurance company, and anyone who is working as part of the facility would be a staffed or a salaried employee of the insurance company. Make sense? So that is the reason why we call it as staff model HMO. Under staff model HMO, the premises or facility would be owned by the insurance company itself, and anyone who is working as part of the facility would be a salaried employee associated with that insurance company. The second type is called as group model HMO. Okay, so what is a group model HMO? Group model HMO is a type of HMO where the premises or the facility in which HMO is running might not be directly owned by the insurance company, but it still would be a large multi-specialty hospital usually, which would sign a lease with the insurance company. And as part of the lease, this multi-specialty hospital would be only providing services to the HMO plans members, and they would not treat anyone outside the plan. Okay. However, premises or facility is not owned by the insurance company, and they only sign a lease or agreement with the ownership of that facility, and they would be providing some lump sum to this management of this facility, and they don't care about the salaries also. So usually they'll pay some money and they will write a contract or agreement with the facilities management, and the facilities ownership or management, they would usually disperse the salaries of the staff who are working in that facility. Okay, and the third type is called as Independent Practice Association or IPA. Okay, what is Independent Practice Association? Independent Practice Association or IPA as we call it is...
Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
A group of independent providers who would be signing the contract with the insurance company as a group. Okay, so meaning all these providers, there might be a bunch of providers who are located in a given area. They would create a syndicate or a network or a group among themselves, and they will sign a single contract with the insurance company as a group. And most of the times, this would not be one single facility. Instead, this might be a bunch of facilities that might be located in a given area, and they were functioning as independent practitioners, and they might have got into contract with the insurance company as a group so that they can run as insurance companies' HMO facility. And finally, the last type is called as network model HMO. Okay, so what is a network model HMO? Network model HMO can be a combination of the first three types. So it can be a combination of a facility that is owned by the insurance company, and along with it, they might have signed a contract with a group of independent practitioners or a single independent practitioner also, or it can be a combination of any type we discussed earlier. If I have to give you some examples, usually the staff model HMOs are the HMOs which insurance company might have either acquired or they have built it by themselves because they have a huge customer base in a given locality. And group model HMOs, usually insurance companies would sign contracts with this multi-specialty hospitals because they still have a large group of customers in that area, but they, for some reason, they don't want to build a facility. So they would pick up a big hospital like St. John's Hospital or some other hospital of that size, and they might be signing a contract with them so that the facility would function as a HMO for this insurance company. And the third group might be a group of providers who might have created a IPA by coordinating with each other, and they would sign contract with the insurance company as a association. And finally, there might be a case where insurance company has a large group of customers, and they know that they can come up with a HMO-based product in that locality because customers would be interested, but they are unable to come up with a staff model or group model or IPA-based HMO. So they might reach out to independent practitioners, and they might create a HMO network by themselves. So the second type of managed care plan is called as PPO plan, or Preferred Provider Organization. So what is a PPO plan? So as part of the PPO plan, you would see that all the drawbacks that we might have identified through the HMO, they would be overcome using a PPO plan. So with HMO-based plan, you have very little choice, meaning you can only go to one facility, or you may be able to go to a small group of independent practice associations or network model providers. Okay, and usually HMO networks are very, very small. Even if they have come up with a network, that network will not be huge. That will be very small. However, to avoid that restriction, PPO plan, in PPO plan, you would be seeing large PPO networks. Okay, so most of us, if you are employed through a employer, and if you are getting health insurance through large carriers like Aetna, Cigna, or companies like that, United Healthcare, you might be having a PPO plan. You can go and check. It is a very, very prominent plan, and most of the employers would provide a PPO-based plan because there will be a huge amount of choice. And PPO networks are very, very huge, very, very huge. And the other important characteristic or difference between HMO and the PPO is that in a HMO, like we discussed earlier, the physician or the hospital would be providing exclusive services to members, HMO's plan members. Okay. However, in a PPO case, a given physician might be participating in more than one PPO network. So a physician might be participating in United Healthcare's PPO network, and the same physician might be participating in Cigna's PPO network also. So they are not exclusive services, and at the same time, there is no restriction that the member should have a member should register himself with a primary care physician. You don't have to choose a primary care physician also with most of the PPO plans these days. However, even if you are choosing a PCP, the PCP can be a in-network provider or a out-of-network provider also. It's up to you. And you can also directly visit a specialist. Okay, you don't need a referral also. Okay, so obviously you see a lot of choice here, right? And based on the rule we discussed in the beginning, if you see a lot of choice, obviously you don't have to you will have to pay a lot of money. Okay, because there is a lot of choice for you as a customer. You will end up paying a lot of out-of-pocket expenses also. This is where you'll see co-pays or co-insurances or deductibles, all that fun stuff. And also the premium would be significantly higher. For example, if I have to quote some examples, for a single person, premium for a HMO plan would be less than $100. Most of the times it would be $70 or $80. Okay, if I know the facts correctly, still. Okay. However, for a PPO-based plan, you might end up seeing significantly higher premiums. So you would not get a PPO network-based plan for less than $150 or $180. Okay, if you are a single person, and if you are a family, it will be even higher. You will end up paying $200 to $300. I'm talking about per paycheck actually. Okay, so these are significantly higher. Okay, and the next type is called as point of service plan. So what drawbacks did we identify with a PPO network? With a PPO network, the difference we identified is, or the drawback we have identified is, with a PPO network, you end up paying a lot of money out of your own pocket. And to avoid this drawback, you have one other type of managed care plan again. So it is called as point of service plan. Usually it is treated as a combination of HMO and a PPO plan. So with HMO, we identified that there is very little choice. And with PPO or with HMO, actually, there is no choice. You can't get services from an out-of-network provider. And with PPO, you can get services from a out-of-network provider, but you will end up paying more money. Okay, so this third plan called as POS plan is called as is considered as a combination of both HMO and a PPO. So what would happen here? You can get your services from a out-of-network provider in POS also. However, there is a very big incentive if you are picking up a provider from the network. So how so? You will end up paying very little out-of-pocket expenses if you are picking up provider in network. However, you have a choice to go and get services from out-of-network provider also. And if you do, you will end up paying significantly large amount of out-of-pocket expenses. So you are given a choice, but also you have an incentive to still pick a provider within your network. And finally, there are one other group of plans called as consumer directed health plans, or CDHPs. So again, there are more than 10 different categories of CDHPs, 10 different types of CDHPs. We don't have to get into the details of them, but I'll try to give you some good amount of details that you might need as a business analyst associated with CDHPs. So what are CDHPs? CDHPs are consumer directed health plans, are the type of health plans which are not primary health plans. Okay, they are secondary or subsidiary health plans to a high deductible primary health plan. So you can't get a CDHP subscription if you don't have a high deductible primary health plan. Okay, so usually let me explain to you with an example. Okay, think that your employer wants to provide you with health insurance. Okay, however, when they start finding insurance companies or reaching out to health insurance companies, they might have identified that most of the health insurance plans are very, very expensive, but still there is a law, so they have to provide insurance to their employees. So what will they do? They will pick up some health plan, and they might be paying some, for example, on an average $250 per employee as a premium to this health insurance plan. And they might end up paying close to, for example, if it is a 24 paycheck based employment or 26 paycheck based employment, they might end up paying some $5,000, $6,000 every year. Okay, but after a couple of years, they did some research and they found that most of these employees are spending less than $1,000 in a given year, okay, towards their healthcare services. But to mitigate that risk, to mitigate some exceptional scenarios where they might run into some additional expenses, employers still don't want to pick a high deductible plan, or they don't want to not pick the good insurance plan. So for this kind of situations, most of the insurance companies, they also offer high deductible health plans. So what are high deductible health plans? Like we discussed in our previous class, deductible is a fixed dollar amount that the member has to bear out of his or her own pocket before he can get the benefits from his health plan. If the deductible is high, your premium would obviously be very less, right? Because you are taking a risk saying that, okay, the member thinks that he would not, or he would end up using very little benefits, so he don't want to pay high premiums. So instead, what he would do, he would pick up a plan with very high deductible. So for example, for a given family, family of 4 people, you can find a high deductible health plan with a deductible anywhere between $3,000 to $4,000 per person at a person level, or $6,000 in total for the family. Okay, so which is a very high deductible. But still, if you are picking up this plan with high deductible, you might end up paying very little premium or significantly less premium. So in our earlier example, we discussed that per paycheck, somebody might be paying $250 if he is picking up a regular plan. But if he wants to pick up a high deductible plan, he might end up paying only $150. So you are saving a lot of money towards the premium. However, if the given person runs into a situation where he needs some specialty services or costly health services, then he might end up paying around $6,000 or $7,000 as deductible. So to mitigate that extraneous situation, a very rare case where a member has to pay a high deductible, to avoid that situation, he can pick up a consumer-directed health plan. Okay, what is a consumer-directed health plan? Usually, consumer-directed health plans are plans where member would be saving some fixed dollar amount or some fixed amount into this CDHPs, usually called as spending accounts, and he would be utilizing that money towards his deductible whenever he runs into a situation where he has to pay a high deductible. And it's not only just about deductible, but he can also utilize the spending accounts, money saved in the spending accounts, towards co-pays or any other out-of-pocket expenses in most of the cases. So what are CDHPs? CDHPs are consumer-directed health plans that are secondary or subsidiary health plans to a high deductible primary health plan. So let me ask the question by myself. So if these are spending accounts or accounts where people would be saving their own money and utilizing the same when they run into situations where they had to support deductible or out-of-pocket expenses, what benefit are they getting by saving this money upfront? Instead, it is their money. They can spend it directly whenever they run into situations. So what benefits are they going to get?
They save on taxes.
Excellent. Good. So that's the reason. That's the primary reason. So they would be able to save on taxes, and they would also be able to invest this money in markets or any index funds or mutual funds or even independent stocks they can pick. Most of the CDHPs, they provide that leverage. So they would be able to utilize that money towards investing out of the tax bracket. Okay. And in many cases, if the insurance is provided through employment, employers would also invest in this CDHPs to support the employees. For example, most of the companies these days, they are preferring or they are suggesting their employees to pick a high deductible health plan, because there are many researchers that say that most of the insureds, they would not be utilizing their benefits regularly. Okay, so employers might think, why should I pay this large amount of money to insurance company and get them benefited? Instead, I can invest some of the money. I can encourage my employee to pick a high deductible health plan, and I would support his CDHP by investing some money into his CDHP from the employer side. Okay, so that is one other benefit. So you would be able to save on taxes, and you would be able to invest that money, and many times you might also get benefited because your employer may also pay for your CDHP. Understood? No, no, it's not a personal insurance. Okay, even with group plans. Okay, so even with group plans, so for example, a given company uh, might provide a choice of three different plans. First one might be a regular PPO plan, and the second one might be a high deductible PPO based plan, and third one might be a very high deductible plan. And if you are picking the first plan where there is little deductible, okay, you would not be able to invest in your CDHPs because you did not pick the high deductible health plan. Okay. However, if you are picking up the second or third plan based on the amount of deductibles your plan has, you might be able to either invest in FSA or MSA or HSA. There are little differences between each one of them, and some of them, if you are investing in a HSA, for example, you would be able to carry over that money. Okay, meaning this year your company might be providing you $2,000 if you are a family. Okay, and you would be able to hold that $2,000 or whatever is left over from that $2,000 after all the money you have spent on healthcare, and you would be able to carry that over to next year. And you'll not believe there are people. I don't know if you guys follow this guy. There is a very popular YouTuber actually. He gives financial advices. He's very popular. Dave Ramsey. Okay, so if you ever follow his show, okay, I have come across a video where he mentioned that he has close to $2 million or so in his HSA account. Okay, so people save a lot by investing in HSA. Okay, because you can invest that money in stocks because after a couple of years, you'll end up seeing more than $10,000 on this account, and your deductible might be only $6,000. So you can invest all the remaining money in your stocks or index funds or anything like that, and you can benefit from the growth. There is some criteria. There is some criteria actually. If I remember it correctly, some of them, there is a cap actually. You can't invest more than $3,000, and some of them you would not be able to invest directly, and only your employer would be able to invest in it. And for some of them, after reaching a certain limit, you can't invest anymore. Okay, but most of them usually will allow you to carry over the money to subsequent year. There is some criteria associated with the eligibility, but it's not much different actually. Understood? And most of these HSA or FSA based plans, even if you have Amazon accounts, okay, you would be able to see that most of the online retailers these days, they have HSA and FSA stores. Okay, so there are certain type of over-the-counter medications, and there are certain types of equipment that are eligible for HSA. So you don't need a prescription also. For example, if you are purchasing Band-Aids or first aid kits, you don't need any prescription. You can use your HSA account money to purchase it directly from Amazon. So, or you can purchase a bathroom scale or BP measuring instruments or things like that. So most of them, they are covered. So these days they have become very, very popular. Okay. Any questions on CDHPs? We understand the managed care plans. Did we understand what is managed care plan and what are HMOs, what are PPOs, what are POS, and what are CDHPs? Are we clear with everything? No, it's not after tax money. It's before tax money. So if your employer is providing you $1,000, okay, that's on top of your salary. Okay, it's not component of your salary usually. So employer would be able to deposit that $1,000 directly into your HSA account. And what would happen, if you, for example, for example, think that you are earning 150,000 every year, right? So ideally, you should get close to $12,000 or $13,000 every month, meaning you should end up getting $6,500, $7,000 every paycheck, right? But if your salary is 150,000, you would have to pay 22% for your taxes, right? And that would be usually deducted at source, meaning your employer would deduct that money and deposit into the deposit to IRS, right? But this $1,000, okay, if they are saying that they would be paying $1,000 to you, then the tax is not deducted in that $1,000. That $1,000 as a whole would be deposited into your account. And fortunately, if you don't have to use most of it, after 65 years, you would be able to pay some tax on it, and you would be able to withdraw all that money. Okay, and if you are investing that money, because most of the CDHPs, they allow you to invest into funds. Okay, so HSA accounts are usually opened with BNY Mellon or Merrill Lynch or companies like that. Okay, so they would allow you to invest. They would allow you to pick index funds, or sometimes even you can pick up your individual stocks. Okay, so for example, think that you have $20,000 in your HSA account, okay, which is before tax, like your IRA or 401k. Okay, so you can invest that in stocks, and you might be able to grow that money at 10% or 15% if you are very smart at investing. Okay, so we will get to that in detail when we are discussing facets topic. Okay, but I'll give you a very high level answer. Okay, so based on your locality and based on the class associated with your with a given customer, for example, there would be some group of customers who would be falling under adult group category, and there might be a group of customers who might be falling under smokers, right? There might be some other group of customers who might be falling under some other specialty category, right? So insurance companies would usually classify their customer base into different classes, subclasses, plans, and groups. Okay, so if you flip your insurance card, you'll see your group number, right? So that decides the product that you are getting. Okay, so class is the classification, like I mentioned earlier. So what type of person you are, meaning what are the characteristics that define you as a consumer to this insurance company. So based on your location, sublocation, class, and subclass, and group, insurance company might be selling a particular product to you. Make sense?
Yes.
You are located in Texas, in Tarrant County, in Fort Worth City, and you are a smoker, just for example, not you. Then you might be eligible for this group of products. Make sense? And again, in the products, there can be a PPO product, there can be a HMO product, there can be a POS product, and it's your choice at that point in time. Understood? So if you are a independent consumer, you would be able to go to state health exchange, okay, and you can provide your preferences, and it will list out all the registered health plans in that state, and you would be able to pick one of them. And however, if you are getting insurance through your employer has the choice. He would be choosing a carrier, and he would be picking up 2 or 3 products, and he would be giving you a choice to pick up from those 2 or 3 products which they have chosen. Hope that makes sense. Okay, we will get to that. We'll get to that when we discuss plan structure.
All right, let's test your knowledge. Here's a question for you. What is a key benefit of using Agile methodologies in healthcare business analysis? Option A, increased paperwork. Option B, longer development cycles. Option C, faster adaptation to changing requirements. Option D, reduced stakeholder involvement. Take a moment to think, and when you're ready, choose the correct option. Remember, each choice holds a key to unlocking the answer. Good luck. Type the correct answer in the comment section. Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes, from patient care to efficient administration. We cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
We talked about different types of health plans, and we broadly classified them into two categories. First one being the government supported health plans, and second one being the private health plans. And we started with private health plans, and where we discussed two different types of private health plans, one being the indemnity plan and second one being the managed care plans. And under managed care plans, again, we discussed four different types of managed care plans. First one is HMO, second one is PPO, third one is POS, and fourth group are CDHPs. And under HMO plans, again, we talked about under HMO plans, we talked about staff model HMOs and group model HMOs and independent practice associations and also network model HMOs. And after that, I think that is where we left in our previous session. In our today's session, we'll continue our discussion further and we will talk about government supported health plans. Okay, so let's get started. So as the name suggests, the government supported health plans are the health plans that are managed and administered and also funded by government organizations. And the first and foremost among them is Medicare. So what is Medicare? Medicare is a federal program attached to the Social Security, and it is available to all US citizens 65 years of age or older, and it covers people with certain disabilities, and also it is available regardless of the income. Okay, so to put it short, it is a government supported health plan that is managed, administered, and also funded by federal government. And as the name, as the slide shows you, it is attached to the person's social security. So Medicare is attached to the social security, and it is available to all US citizens who are 65 years and older. So the eligibility criteria is age of the person, and if anyone is 65 years or older, then he or she is definitely eligible for Medicare. However, there are a lot of exceptions, and in some special conditions, people who are less than 65 years and older are also eligible for Medicare. And again, there is no income-based restrictions, only age is the limitation. And in spite of income level of the person, everyone who is older than 65 years would be eligible for Medicare. Again, some of the Medicare, some of the government supported health plans, they are funded by federal government, but they would be administered by some other government organizations. But in this case, Medicare is totally funded and also administered by federal government. Understood? And again, we don't have to get into too much details, but there are 4 different parts inside Medicare. They are called as Part A, Part B, Part C, and Part D. And at a high level, Part A is about providing inpatient services or eligibility for inpatient services and also nursing care, because understandably, the focused audience for Medicare are people above 65 years. So nursing was the major benefit that anyone would expect. So it is part of Part A. And outpatient care and also doctor visits in some cases are part of Part B. And the original Medicare only constitutes Part A and Part B. So everyone or most of the people would be eligible for Part A and Part B. And there are 2 other parts called as Part C and Part D. Part D majorly focuses on prescription drugs or pharmacy benefits, and Part C is Part C deals with some miscellaneous benefits, and most common among them are premium benefits towards subsidiary health plans. So you can purchase a secondary health plan from a private party, and you can get benefited through Medicare for the premiums paid towards the secondary or private health plan. Okay, so at a high level, that's about Part A, Part B, and Part C and Part D and Medicare. So if you have any questions, we can discuss. Otherwise, we'll move on to Medicaid. So Medicaid, again, is a government-supported health plan, and Medicaid is funded by both federal and state governments. However, it is administered only by the state governments. So what does that mean? That means Medicare is administered by state governments, meaning they manage it and they provide the benefits. However, the funding part of it is done on a shared basis, meaning federal government might be paying some portion of the Medicare funding, and remaining portion should be borne by the state government. And like you might have already noticed, it is administered by state. So there are around 50 different Medicare plans, Medicaid plans, because each state would have their own Medicaid. And what is the eligibility criteria for Medicaid plans? People with low income are eligible for Medicaid. So major criteria in Medicaid's case is people with people who are 65 years and older. But in this case, the income is the major eligibility criteria. Make sense? And again, like I mentioned in the beginning, it is jointly funded, meaning the federal government would also bear costs associated with Medicaid. And however, the funding provided by federal government is not uniform, meaning some states may get more money and some other states may be getting less money from federal government towards Medicaid implementation. And how is that decided? So ideally, most affluent states would get less funding from the federal government, and they would have to bear most of the expenses or funding from the state side. However, financially less affluent states may get more funding from the federal government. And the third plan is a third government supported health plan is CHIP, or Children's Health Insurance Program. So as the name suggests, it is directed towards children. So not all children are eligible for CHIP, but children from economically lower backgrounds or less affluent children are eligible for CHIP. And again, it is funded by both federal and state governments, but it is administered by the state governments. Some of the state governments, they do it as part of the Medicare, meaning they may not have separate CHIP plan, but CHIP plan is embedded as part of the Medicaid. But most of the states, they cover it separately, and that's the reason why it gets called as SCHIP, State Children Health Insurance Program. Okay, so that's about CHIP or SCHIP. And the next important government supported health plan is Federal Employee Health Benefits Program, or FEHBP as we call it. And as the name says, FEHBP is focused towards federal government employees. So it's a employee benefit plan. So federal government employees get this, they would get this benefit, and most of the times services or benefits are administered through some designated hospitals. In this case, there are some hospitals which provide only benefits to federal government employees. And again, most of the times the retired employees, they also get benefits through FEHBP, and in some cases survivors would also get benefited through FEHBP. And also employees dependents, obviously. Is it clear? Did we understand FEHBP, Medicaid, CHIP, and Medicare? Finally, there is a plan called as TRICARE. So what is TRICARE? TRICARE provides civilian health benefits for military personnel. So what does that mean? Armed forces people, they get benefits through TRICARE. So in most of the cases, armed personnel and military retirees and the dependents would also get benefits through TRICARE, and reserved forces people also would get benefits through TRICARE. And retirees, again, I can share with you some funny incident or interesting incident that had happened a couple of years back in one of my earlier batches. I think around 2014 or 15. I don't know if it has changed after that, but around that time, I used to have, in this slide, I used to have some dates mentioned in it, or number of days of eligibility mentioned in it. I used to mention that retirees from armed forces, they would also get benefit from anywhere between 6 to 9 months, okay, at that time, because again, obviously, I did not work in armed forces, so my knowledge was derived from some online documentation, okay. But there was a retired person from armed forces. He used to be Eugene, if I remember his name correctly. He was from armed forces, and he just retired actually less than 6 months from his tenure, and he corrected me. He told me that no, this has changed, and these days most of us, we are getting only 90 days, or some of us, we are getting 90 days, or there is some more detailed eligibility associated with benefits after retirement, and this might not be valid all the time. So to avoid confusion, I removed that duration, because obviously as a business analyst, it doesn't matter much for you. Okay, so TRICARE is directed towards military personnel, and also retirees and survivors and dependents would also get benefits, and also the reserved component. Also, TRICARE is mostly administered through military hospitals, or hospitals that are maintained by armed groups, actually military people. So and the benefits are most of the times encouraged through this armed hospitals, wherever military hospitals, wherever they are located. Okay, so that's about TRICARE. So what are the 5 different types of government supported health plans: Medicare, Medicaid, CHIP, and FEHBP and TRICARE. So these are the 5 different types of government supported health plans. Again, it's a very debatable concept, and if you follow news and if you follow uh, mm, online news portals, you might have heard of it many times. So even in a case where you are eligible for government support or government-based health plans, you might not be getting 100% coverage. Okay, there are many clauses around it, and there are it totally depends from case to case. And like I mentioned in the first case, Medicare is tagged to your Social Security, so it depends on how much money you have in Social Security also. And however, again, thanks to Obamacare, uh, service cannot be denied to anyone. Actually, you need to be provided with service in most of the emergency cases. Okay, that might not cover uh, long-term chronic ailments in some case. Sorry, Obamacare is a legislation. Okay, so it's not a care plan. Okay, it's a legislation that says, okay, there are multiple components to it. Again, it's a very broad plan actually, or very broad legislation, and there are many components like ARA Act and High Tech Act and all those other stuff would also fall under Obamacare. But at a high level, Obamacare is about providing benefits to everyone, meaning you can't deny service, is what it says. No, there are, again, okay, I would not get into some unlawful incidents that usually happen, but there are cases where people from other countries, they come to US, or they are in US for some reason, and they get ill, and they get all the services because the legislation or the law says that you can get the service. And there are situations or examples where people did not pay the bill because it was very huge and they don't have insurance, and they ended up saying that they can't pay and they left the country. And I don't know what happened after that, but it happens actually. As long as you are in the country, you're covered. Okay, just to do a quick recap of what we discussed as part of our first module, we started with understanding what is insurance and what is health insurance, and we discussed all the key terms and terminology associated with it, and we discussed the terms associated with the cost, and we discussed the reimbursement process and the number of different ways associated with it, and we discussed the terms, commonly used terms associated with the insurance, like coordination of benefits and cost shifting models, etc. And after that, we started understanding the private health plans, and we discussed all the different types of private health plans, and we moved towards government supported health plans, and we discussed them. So with that, we will conclude our first module, and we'll move on to our second module, where we will start discussing healthcare claims process. So usually they would ask for your tax returns. Okay, so based on your previous year's income, okay, your tax statements are the proofs that you would have to provide to showcase that your income is less than what they have quoted. And if I remember it correctly, Kiran, usually they would be there is something called as uh, mm, what is that, federal poverty line or something. Yeah, yeah. So it is 20% above the federal poverty line or something like that. Depends from state to state actually. So it might vary quite a bit between the states, but that's how it works. So our next topic is healthcare claims process. Okay, so what is a claim? Can somebody explain me what is claim? What's your understanding of what a claim is? So a claim is a formal request for reimbursement. Okay, and this formal request for reimbursement is submitted to the insurance company on behalf of the insured to get benefited for the services that are provided to him. Okay, and the reimbursement is the amount that gets reimbursed totally depends on the insurance contract between the insured and the insurance company. So what is a claim? A claim is a formal request for reimbursement submitted on behalf of the insured to the insurance company. Okay, so when would we submit this claim or request for reimbursement? It would be submitted after the services are provided to the member, right? So when we go to a hospital, okay, so most of us would have visited a clinic or a hospital or any provider with our insurance, right? What would happen? The first thing that would happen is the hospital would ask you for your insurance card, right? Ask you if you are insured, and they will ask you for your insurance card. Or in some cases these days, they ask you to fill up a form, and as part of the form, usually the process is called as pre-registration process. And as part of the form, you will see a section where they will ask you to mention your insurance details. And the second step would be hospital staff or the front desk people. They would pick up your documentation and they will uh, do a process called as benefits verification, meaning they will reach out to your insurance company to see if you are a valid customer of the company. If yes, what are your benefits, and whether the services you might be looking for, whether they are covered as part of the insurance or not. And that way, and also in some cases, they would also see what your copay and co-insurance and deductible details are. So that way, if they have all those details upfront, they would deduct or they would ask you to pay for the out-of-pocket expenses in advance before they provide the service, and they would go back to the insurance company to get the remaining amount claimed from the insurance company. So that's how it works. So again, what is a claim? A claim is a formal request for reimbursement submitted by the submitted on behalf of the member to the insurance company. And when would it be submitted? It would be submitted after the services are provided. Okay. And what's the big deal? Why are we uh, mm, uh, dedicating one module or a couple of modules towards understanding claims or claims process? So when you are aspiring to be a business analyst, or as a matter of fact, any IT person in healthcare domain, where does most of the jobs exist? So most of the jobs exist with insurance companies, right? And also, after insurance companies, the second major area where you might find a job is with providers, right? And claim is associated with both providers and also the insurance companies, right? Because providers will have to submit the claim and insurance companies will have to process the claim. And there are many associated processes that are related to healthcare claims. And there is a lot of regulation associated with claims processing also. And you will also notice that there are few other parties that are also involved as part of healthcare claims, like CMS, which is Center for Medicare and Medicaid Services, which is part of HHS, which is Department of Health, and CMS is the highest regulatory authority. So there are certain flows associated with healthcare claims process that would involve CMS also, and we'll discuss that in detail later. And also there are many third-party administrators involved in between the provider and payer as part of the claims process. So it is not a simple process. It is a very, very thorough and complicated process. And again, apart from that, when you are applying for jobs, you will start noticing that most of the jobs would require some claims knowledge. Okay, why is that so? Because claims process in healthcare require some specialized skills and thorough knowledge in that area. Okay, so because they are a bit unique when compared with the regular claims. And also, claims is cost center for any insurance company, not only health insurance, but also property and casualty or general liability, workers' compensation, any type of insurance you might be dealing with, claims area would be their cost center. So what does that mean? That is the business unit where you will see a lot of cost involved, right? So for example, if you are a big size insurance company and if your return premiums are, just think that it is $1 billion, then you might end up seeing anywhere between uh, mm, 200 million to 250 million dollars going towards claim. So, and it is money that goes out. Okay, it's not the money that comes in. So that's cost. So wherever there is a lot of money involved, and in particular, if it is cost that is involved, people will start looking for or people will start identifying ways to make that process effective or ways to automate it so that there is no unnecessary cost that is involved, or there are more effective ways of identifying and reducing costs. So due to all these factors, you'll start noticing that claims process in itself is a complex process, and it requires some in-depth knowledge or specialized knowledge, particularly in healthcare area. Okay, so before we get started on this topic, I want to explain you few terms which we might come across when we discuss the topic. Okay, so having knowledge on those terms would help you. First one is called as healthcare clearinghouse. So what is a clearinghouse? Like I mentioned earlier, there are many third-party administrators between your provider and payer, meaning if there are some transactions that are happening between your provider and the payer, they would, most of the cases, they would not happen directly. So they would be happening between the provider and third party administrator, and also between the third party administrator and also payer. Who is payer? Payer is the insurance company, like we discussed earlier. Okay, so why do we need, and clearing houses constitute the best or largest portion of TPS or third party administrators. And what does these clearing houses do? Okay, clearing houses is a public or private entity that does either of the following functions. First thing, processes or facilitates the processing of health information received from another entity in a non-standard format or containing non-standard data content into standard data elements or standard transaction. Okay, and the second one is receive a standard transaction from another entity and process or facilitate the processing of health information into non-standard format or non-standard data content for receiving entity. So what does this mean? Okay, next time when you visit your physician, okay, if you have a good relation with your physician, ask them how complex is the claim submission process. Okay, they will tell you that it's a very complex process. Okay, how would that work? When you go to hospital, okay, you meaning anyone, okay, so when somebody goes to the hospital and when they get the service, you will start, or you will notice that the first step is registration and pre-registration, like I mentioned in the beginning, where they will get all the details and demographics associated with the member, and they will document them. And second step is they will provide the service, right? When they provide the service, while providing the service, they would capture all the required details, like what is the ailment with which the patient is suffering and what services we have provided, and uh, mm, all other clinical details associated with it, okay, like the procedure codes or diagnosis codes and all other required details would be captured as part of providing the service. So it would be a huge amount of data, right? And we will look at it, or we'll get to details of it when we look at the claim forms and EDI documentation. But you will understand later that this is not simple set of information. Okay, there are a lot of details that needs to be captured as part of claim submission. So the clinics or hospitals or any providers, they will capture all those required details, and they will submit the documentation along with the claim request to the insurance company. So when they send this detail to the insurance company, they can't send it in their own format. Okay, they can't send it in any format in which they maintain their documentation. Instead, there are some predefined standards that needs to be followed to submit the claims. Why do we need to follow that? Because as we discussed in our earlier class and the first module, there are a lot of providers involved in providing healthcare services across the country, and at the same time there are a lot of payers also, and everyone will have their own way or standard of documenting the details. So to avoid confusion, there is a regulation that says, okay, you can submit or you can perform transactions between healthcare entities or healthcare business entities in only certain standard format. So if you are submitting a claim, the claim should be submitted only in certain format. And if you are responding to a claim, you should submit the response, or you should send the response only in certain format. And if you are sending explanation of benefits, you should submit it in only certain format. If you are submitting remittance advices, you should submit it in only certain format. If you are submitting a pre-authorization request or additional documentation request, there is a format for it. So documents are transaction details, they need to be submitted in predefined standards. So if you are a small physician office, um, it is very hard for you to standardize your documentation based on approved standards to be able to submit the transaction to your business partner, which is the insurance company. And why is it so? Because regulations keep changing a lot.
Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
It is not your primary business to catch up with the regulatory changes, and also standardizing the documentation and going through all that pain. So usually providers, they will rely on third-party administrators or clearing houses. So what will they do? They will send all their non-standard documentation associated with the transaction, for example, claim, to the third-party administrator called as clearinghouse, and this clearinghouse will convert that data. They will review the data, they will convert it, and they will standardize it. Okay, and there are two different types of standardization broadly. First one is EDI based standardization. If you are submitting these transactions in electronic format, and if you want to submit paper transactions like paper claims, there are predefined forms that are approved by CMS also. So you have a form type called as UB04, you have a form type called as CMS 1500, and based on the type of claim or type of billing, you will have to pick up the right form and put in all those details in the claim form and send it in physical mail to the insurance company. So what this clearinghouses does is they will pick up the non-standard data from their business partners, and they will translate it into standardized format, and they will send it to the insurance company. And in return, when they get back the standardized data from the insurance company, they will convert it into understandable format and or non-standard format and send it back to providers. Make sense? So did you understand who a clearinghouse is? CMS. It's part of the regulation actually. Like I mentioned earlier, Ashish, CMS is the highest regulatory authority in US pertaining to healthcare actually. So they come up with the regulation and they keep updating the forms, and they keep updating the EDI transactions also. For example, before 2011, we used to have a EDI transaction set called as 4010. And for example, again, just to give you an example, with that 4010 based EDI transactions, they used to capture everything in units. Okay, however, meaning the service units. So if somebody goes to a hospital, so they used to capture everything as a unit, meaning hospital visit is 1 unit. Okay, and room service is 1 unit, and IV is 1 unit. Okay, however, everything can't be a unit, right? Because IV can be a unit, but uh, room service is not a unit. It should be calculated in days, right? So number of days the service is provided. So they keep updating their transactions. So they updated 4010 transaction to add 2 different types of units, whether it is days or units. And they added some additional details like ambulance related services, and getting consent from the member on disclosure of the information, and capturing the URLs, and capturing the details as part of EDI forms. So they keep updating these forms. So there is a regulatory authority who maintains these forms, and they also do the same with physical claim forms. They keep updating CMS 1500 and UB04 claim forms. And if you want to look at it, go to a online retail store like Amazon or eBay, and search for CMS 1500 claim forms. You'll see that they are sold online. So you can't come up with a format, and you can't, or even if you are following the same format, you can't download the form, and you can't uh, mm, print it by yourself. So you'll have to purchase it from somebody. Okay, so you'll purchase it and you'll fill the form and send it. Make sense? So there is a regulatory authority. Exactly. Again, it's a very debatable concept, and when you get into your job in healthcare, particularly if you get a chance to work in claims area, okay, you will start noticing that there are many intermediaries. Okay, so most of the times, if you are either you are working with insurance company or the provider, you'll start noticing that there will be a lot of intermediaries or TPAs that will be involved. Okay, and like I said, go talk to your physician next time when you get a chance. Uh, you will hear their complaints. Okay, it's not an easy business. So there are many third-party administrators or third-party organizations like clearinghouses that make a lot of money. Okay, for example, again, I'll not take names for obvious reasons, but I have worked with a very big insurance company earlier, and while I was working with them, I got a chance to meet with somebody who has been in this business, who has been associated with regulation, and who has been dealing with this third-party administrators for past 30 years or 40 years actually. And I heard from him actually that these third-party organizations, they charge both the parties, meaning insurance companies and also the providers, uh, some amount on every transaction they process. Okay, and so they are a very huge lobby actually. They'll lobby at a state level, and also they will lobby at a federal level, and they will get regulations that would benefit them. Okay, they would try to get regulations that would benefit them. So what would happen? Most of these standards, you will also notice that there are some standards which doesn't make sense in 2020, but still they exist because there is a huge lobby involved and there are people that are profiting a lot. And if I have to give you an example, again, the companies that I was dealing with, they were in Boston area actually, and you'll see that a lot of software companies and this third-party administrators, they exist in our standards development companies. They exist in Boston actually. They get paid in royalties and they get paid for for a transaction they processed. And think of a example where there is a state like New York, and every insurance company, they might be processing around 10,000 transactions from the state every day. And think that there are 50 small and large scale companies from that state, and a transaction would go through 5 different intermediaries end to end. Okay, and each one of them is charging 50 cents per transaction, or it's not 50 cents, it would be around if I remember it correctly, it's around $1 or $1.50 actually. So if they are charging $1, okay, for example, and they are processing uh, 20,000 transactions per day, intermediary. Okay, think that it is a small scale company. So they will not do anything. They have established systems, and they have which they might have developed long back, and they have regulations and formats in place, and only thing they would do is allow these transactions flow through their systems, and they would be earning a lot of money. Okay, and there are many companies like this actually, and there are some third-party organizations which have monopoly over states. Okay, meaning they would be earning huge revenues at the scale of an insurance company actually. It's a huge business. And again, on a positive side, that's the reason why we are learning this, because all these companies have jobs also, and that's the reason why healthcare is a complex subject and there are a lot of jobs in that area. That's the reason why we are calling them as TPAs actually. Okay, if you are a clearinghouse, you would be translating clinical documentation into a claim form, right? Like a CMS 1500 or UV04 or 837 transaction or things like that, right? And when you get back the payment, okay, so you'll be receiving a 835 transaction, or you would be receiving a remittance advice, and you would be again destandardizing it and converting it into a readable format and sending it back to the provider, right? However, if you are a transcription company, okay, so what you will do is somebody will submit a claim to the insurance company, okay, but they would not directly submit it to the insurance company, but it will go to a clearinghouse, and the clearinghouse will send it to a company that does transcription, okay, or that acts as a gateway for all the documentation that is received by the insurance company. So what will they do? They'll pick it up in a physical format and they will image it, they will scan it, they will copy it, and they will send it to the insurance company in digital format and load it into their systems. Okay, that's one other type of TPA. Okay, it's not a clearinghouse. Okay, and in some cases, providers will send clinical documentation to somebody else because you might be receiving the documentation, clinical documentation, like a MRI document. They can't read it directly, right? So they will send it to some transcription company which is good at reading through medical documentation and documenting the results out of it. So if it is a MRI, they will read through the MRI and they will capture all those details and put it in a document. And it would be sent to somebody else who would pick it up and pass it to the other business partner. So there are multiple types of companies again. So that's the reason why we call them as intermediaries or TPAs. And clearinghouse is one among them. Okay, so the next important term you would come across is claim adjudication, right? So what is adjudication? Adjudication is nothing but taking a decision. Okay, so when you submit a claim, insurance company should take some decision on the claim, right? So the decision can be a approval or a denial or putting it in a standby or a pending mode, right? So whatever might be the decision, the claim would be called as adjudicated when a decision is made on it. Make sense? So what is adjudication? Claims adjudication is a term used in insurance industry to refer to the process of paying claims submitted or denying them or comparing claims to benefit or coverage requirements. So at the end, any decision or taking a decision on a claim is called as adjudication. So again, there's a much complex slide, but let me give you some details that would help you in understanding it before we get into a claims workflow. So what is a workflow or a life cycle? Okay, so as we discussed during our introductory session, a workflow or a life cycle is a series of stages associated with a process, right? So, for example, if I ask you, explain the life cycle of a butterfly, you'll say it would start as a cocoon or it would start as a larva and it would translate into something else. It would translate into caterpillar and it would translate into something else before it becomes a butterfly. Likewise, every business process will have multiple stages and processes associated with it from its starting point till its desired state. So likewise, even for our healthcare claim, there would be multiple steps associated with a healthcare claim in between from the point where it gets initiated till the point where it gets adjudicated and paid if required. So as part of this module, we'll try to understand what is the life cycle of a claim, okay, or what is the workflow associated with a claim. And again, to understand it at a very high level, the claim workflow can be categorized into a couple of stages at a high level. The first thing is called as claim intake, right? So what is claim intake? Claim intake is the way using which, or the way a claim would be accepted by an insurance company. And for example, you can submit the claim, like I mentioned earlier, as a physical paper or a physical form, and you can submit it as a electronic or EDI document, meaning you will send it using EDI systems like sending an email. Okay, it would we'll get into details of it when we discuss EDI, but it's a way of electronically submitting the request. And there might be a third way. Some of the companies, they expose online portals. So providers or clearinghouses, they can register themselves with the insurance company and they would get access to these portals and they would be able to log into this portal and submit the claim using their website or web portal. So likewise, there can be multiple different ways in which a claim can be submitted to the insurance company. And this step would be called as claim intake. And the second step is called as claim handling, okay, or claim processing. So as part of this process, the claim that is being accepted by the insurance company or claim that is being received by the insurance company would be imaged, and meaning you would take a copy of it and save it in your database. Okay, if it is a physical paper claim form, you would scan it and store it for future reference. And if it is a EDI document, you will create a copy of the EDI document before processing it. And in some cases, if it is received as a paper claim, you can't process the paper claim using your electronic systems, right? So you'll have to convert the paper claim into some digital format. So there is a keying in process involved, meaning somebody would have to manually key in that physical claim form into their claim systems, okay, so that the data exists in their claim systems, okay. So some companies also involve digitizing systems, meaning NLP engines or bots that would automatically pick up the physical claim form and read through it automatically and save it into their database. Okay, so next step as part of the claim process would be running through their validations. So every company will have their own set of validations, right? They'll have to see whether the given person is eligible or not, whether this given person has the benefits covered or the benefits that were received by the member are covered as part of his benefits or not. Likewise, there will be a lot of edits or validations that the payer would be running on the claim to make sure that, or to make a decision on whether the claim can be approved or denied, right? So uh, that would be the next step as part of the claim processing. And the third step would be claim adjudication. So based on how the validations ran, or how the edits ran, you would have to take a decision on whether the claim can be approved or denied, or if you need additional information to be able to get that or make that decision. So if you need additional information, then you would put it in a pending state. So that process of taking a decision on the claim would be called as adjudication. And in many cases, it would happen as a two-step process. The systems would be automatically adjudicating the claim and automatically taking a decision. And in some cases, based on a given scenario, based on the given scenario, it may require additional manual review or manual adjudication. So some adjuster or a claims analyst will have to do some secondary review, look into the details, and if required, they'll have to approve it manually, or they'll have to reject it based on the flags that were raised. And after the adjudication gets completed, the final step would be making payments. Okay, meaning if it is approved or if it is partially approved, then you will queue it for payments, and payments in itself is a different process again. Okay, so these are the four steps associated with claim life cycle. So what are the four steps? Claim intake, claim processing, and claim adjudication, and payments. Does that make sense? Good. So we will look at it in detail, and also we will try to understand the claim life cycle from three different perspectives. We will try to understand it from payer's perspective, or the insurance company's perspective, and we'll also try to understand it from provider's perspective, and we'll also try to understand it from claim management systems perspective, or IT systems perspective. And so that we will get overall knowledge around the healthcare claim life cycle. They will actually, if you are looking at a multi-specialty hospital, or if you are looking at a large hospital setup, like a big ambulatory surgical center or a chain of hospitals, they'll have their own centralized billing offices. They call them CBOs. Okay, but if you are looking at smaller clinics, okay, like a physician, okay, it doesn't make sense for them to go through all that pain. Okay, they are well off leveraging a third party administrator to do the processing, because it involves dedicated people who would capture the details. And like I mentioned earlier, there are multiple steps associated with it from the provider's perspective also. So there is something called as coding, and there is something called as billing, and there are some specialized steps. Actually, you'll have to uh, mm, look at the documentation, and you'll have to find what services are provided and what are the ailments, and you'll have to translate the services into procedure codes and ailments into diagnosis codes, and you'll have to find the appropriate location codes. And if you are a specialized facility, you'll have to have a taxonomy code, like I mentioned, and you'll have to translate those procedure codes into revenue codes, and you'll have to find revenue codes, sorry, billing amount associated with the revenue code, and you'll have to translate that into a bill. Okay, and you'll have to submit it. It's a lot of processing actually. It doesn't make sense for a small facility to do that. Yeah, taxonomy code is For example, think that you are a adult care facility. Okay, all the adult care facilities will have their own taxonomy code. Taxonomy code is associated with specialty services that are provided by a facility. Okay, and likewise, if you are a pediatric hospital, then you'll have your own taxonomy code. It's a 9-digit code actually. We will discuss that. Taxonomy codes are specialty codes. Yeah.
Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
Okay, so what are the elements of a claim? So when we say elements of a claim, we are talking about data elements of a claim. So when you try to read through a claim, or if as an insurance company, you would need to review a claim and you would have to adjudicate it. Okay, you can't just go by the basic details like what's the name of the person and what is the claim number or what is the policy number associated with the person and what is he asking for, right? You would need additional details. Like I mentioned earlier, most of the insurance companies, they will have a lot of edits they would be validating as part of the claims processing, and they would go into hundreds. So there will be hundreds of validations they would be doing as part of a claim adjudication process. So for them to be able to perform all that validations, okay, you would require a lot of data associated with the claim. So your claim forms, which are approved by CMS, like I mentioned, the standardized claim forms like CMS 1500 or UB04 claim forms or the EDI 837 transactions, all of them, they would contain or they would expect you to submit a lot of information as part of the claim forms. So for understanding purpose and for simplifying the way the data elements are represented, we will classify them into 5 categories. First one is member information, and second one is provider information, and third one is coordination of benefits or other health insurance information, and next one is procedure code details, and after that you will have diagnosis code details. And that is not all, okay, but this would constitute most of the data elements you might see on a claim form. And again, claims are generally broken down into 2 types, okay, based on the type of billing associated with them. The first type is called as professional claims, and the second category is called as hospitalization claims. It's self-explanatory, right? A professional claim is a claim associated with services provided by physicians, or to put it straight, professional claims are the claims associated with outpatient related services. So if somebody goes to a hospital, or if somebody visits a physician, or if somebody visits a specialist, or get any outpatient services, all of them, they would be categorized as professional billing or professional services. So claims associated with professional billing are called as professional claims, right? And the second category is called as hospitalization claims or institutional claims. So as the name suggests, again, hospitalization or institutional claims are claims associated with hospitalization billing, meaning any services that are provided as inpatient services, they would be classified as hospitalization claims. Okay, so let's try to understand the elements again. We'll come back to this. Okay, so regardless of type of claims, regardless of whatever might be the type of claim you are dealing with, the 5 different categories of information which we discussed earlier, they would be captured across both the type of claims. So the first type of claim information or first type of data elements you would be seeing are called as are associated with member information, right? So who is a member? Anyone who is getting the services is called as a member, or anyone who is getting the service through his health insurance is called as member of that health insurance plan. And what details would you need on related to a member information? You would need details like member's name, member's address, member's date of birth, and ID numbers, and member's employment details, and member's school details if required, and number of days of leave, and number of days of time off you need to take because of the disability, and all that details associated with a member are captured as part of member information, right? And after that, you will also have to provide the provider information. Who is a provider? Anyone who provides the health related service is called as a provider, right? And it can be a lab, or it can be a physician's office, it can be a multi-specialty hospital, it can be urgent care, it can be emergency care, ER room, or it can be a hospital which would provide specialty services like chiropractic or the physical therapy or things like that. Okay, so provider information, and again, the most important details associated with the provider that needs to be captured as part of the claim are provider ID, provider's tax identification number, and address associated with the provider. Understood? Is it making sense?
Yes.
Good. Sometimes you might have to capture the details associated with more than one provider. Why would we have more than one provider associated with the same claim? Okay. For example, think that patient went to a physician and physician asked him to visit a specialist, and he gave him a referral. In this case, specialist would be the billing provider, okay, and the physician would be the referring provider. So who is a billing provider and who is a referring provider? Anyone who would be, or the provider who would be submitting the claim to the insurance company is called as a billing provider. And sometimes you can also have a referring provider, meaning somebody who has referred the patient to the billing provider is called as a referring provider. So in this case, physician would be called as referring provider, and specialist would be called as billing provider. And it's simple. Any provider who would be the last node in the whole service chain would be the billing provider, obviously, if he is submitting the claim on everyone's behalf. So when billing provider provides the or submits the claim, he may also, or he would also be able to capture the details associated with services provided by the referring provider and also submit the bill on his behalf. Sometimes providers or hospitals, they coordinate among themselves and they would submit one claim, and they would also include the services that are provided by other provider or every single provider as part of the same claim. So in that kind of cases where the billing provider and referring provider also exist as part of the claim, then you would have to capture the same details for all the providers that are involved. Make sense? So coordination of benefits is a concept where you can get benefits from all the insurance plans you are covered under, right? So in this case, you would also include other health insurance or coordination of benefits details as part of the claim. So like I mentioned earlier, if you are sorry, you meaning anyone, if a given person is having insurance with a health insurance company, and his employer also covers him through workers' compensation insurance. And while he's on work, okay, he met with a auto accident, and in that case, what would happen? The member can get liability insurance from the other party's auto insurance, and he would also be able to get the workers' compensation benefits, and he would also be able to get his auto insurance related benefits, and he would also be able to get the benefits from his health insurance plan. So it's essential that you would include all the details associated with all the insurance plans where the member is enrolled as part of the claim. Okay, so that member can get most benefit out of his enrollments or out of his insurance plan. However, there is the other side of it. How many of you have submitted a quote to get auto insurance on Geico or Progressive's web portals? So, did you ever notice that there is a checkbox that says, I have health insurance, and I would quote my health insurance as the primary insurance in case of an accident, right? Next time, pay some attention to that, because if you check that checkbox, your premium would go down very, very significantly. Okay, and why is that so? Because the auto insurance company is transferring most significant risk to the health insurance company. Making sense? So they are saying that they are getting your consent to make your health insurance primary in case of auto accidents. Right? And again, you can do that, right? Because health insurance is very, very costly, and you don't want to pay more on one other insurance when your primary health insurance covers that risk. You still need to get liability insurance, but what they are saying is health benefits are covered in some cases. Like we discussed, coordination of benefits would apply, right? You may be eligible to get benefits from your auto insurance, and you may be able to get it from workers' comp, and you may be able to get it from health insurance also, right? So in that case, if you have the choice, who would you quote as the primary insurance, right?
Okay, I see.
So let me give you an example. Think that a given person has all the three insurances we discussed, and through his health insurance, he is eligible for getting $30,000 as benefits, right? And through the auto insurance, he is eligible for another $20,000, and through his workers' compensation, he is eligible for $10,000, right? So in total, he is eligible for getting a benefit up till a limit of $60,000, right? And he met with an accident, and unfortunately, he had to spend around $12,000, for example. Make sense? So in this case, when he's purchasing the auto insurance, if he has quoted the health insurance as the primary insurance in case of an auto accident, health insurance will take the precedence. So they would have to cover all the expenses first up till the limit. So what will happen? It is $12,000, and the limit on his health insurance is $30,000. So health insurance company would end up paying the money, right? But if he has quoted the auto insurance as primary, then auto insurance will have to pay that money, or they'll have to reimburse it, right? So they are transferring significant amount of risk to health insurance companies. So the risk associated with policy will get reduced significantly. So they can give you the insurance for less premium. So that's how it works. Okay, so and again, for example, think that the same person ran into expenses of $35,000. What would happen? You can quote first primary, secondary, tertiary, and subsidiary plans on your claim. You meaning anyone. So what would happen in that case? $35,000 is the limit. So what would happen? Member would submit it or quote all the insurance plans on his claim. So the claim would be first submitted to primary insurance. which would be health insurance, and they would reimburse $30,000, and still there would be some $5,000, additional $5,000 on the claim. So health insurance company will submit a secondary 837 or electronic claim form to the auto insurance company, and auto insurance company will reimburse remaining $5,000. Make sense? So that's the reason why you would need all the coordination of benefits details on a healthcare claim. The next important group of data elements are procedure codes. So what is a procedure code? A procedure code is a code associated with or code that defines the procedure that has been applied or service that has been provided to a patient, right? So procedure codes are that define what services have been performed. And on medical claims, they are also called as current procedure terminology or CPT codes. And procedure codes give a precise description of what type of service performed, and they are also the mechanism by which the exact level of reimbursement is determined and hospitalized. Okay, so we will discuss them in detail when we discuss healthcare coding, but at high level, understand that procedure codes are the codes that define the services that are provided to a given patient, right? So if somebody visits a hospital and he goes there for a hospital or physician visit will have a procedure code, and he gets his test done with a lab. So each one of those tests will have a procedure code, and they talk about CPT and HCPCS codes, right? So CPT codes are nothing but the codes associated with professional billing and or professional services, and HCPCS codes are the codes associated with institutional or hospitalization services. And again, just to give you some additional details, these codes are universal. Okay, so they are not specific to United States. So they are maintained by WHO, and they are accepted or they are followed across most of the developed countries. And earlier with ICD-9 version of codes, we used to have only CM codes. Okay, and CM codes, classification of medicine, I guess CM means, and there used to be 3 volumes of CM codes. One would represent procedure codes, and remaining 2 used to represent diagnosis codes. And now they have added a lot of procedure codes with latest version of coding dictionary, which is the ICD-10 coding dictionary. And with that, they have a lot of CPT codes and a lot of HCPCS codes added to the coding dictionary. Okay, so that's about it. So the procedure codes would define the service that is provided to a patient, and on any given claim, you would be able to list out all the procedure codes associated with the service. And on a claim form, you would also see details associated with description of the service provided. So you would be able to provide the description of the service, and you would be able to list the procedure code associated with that service. Make sense? Again, like I mentioned earlier, there are 2 types of billing. One is called as professional billing, and professional billing is also called as medical billing in layman terms. Okay, in informal terms, it is also called as medical billing. And the second group is called as hospitalization claims or institutional claims. And the procedure codes associated with institutional claims are called as level 2 codes actually, or the procedure codes associated with professional billing are called as level 1 codes. And again, this is very, very informal. Okay, these days, everyone is aware of the technology and they keep using the terms HCPCS and CPT codes. And again, there are multiple types of codes that are used actually. UK uses a different set of codes. They along with ICD codes, they also use SNOMED codes. But again, we don't worry about them too much because they are not prevalent in United States. The next type of codes are called as diagnosis codes. So what are diagnosis codes? Diagnosis codes are the codes, again, they are ICD codes, and they are managed by WHO again. And diagnosis codes would represent the patient's condition, or these are the codes that are used to define the patient's ailments associated with the patient. So if somebody visits for a routine child health checkup, okay, you'll see a code called as V20.2. This is an example again. And delivery in normal complete case has a diagnosis code. Likewise, every single ailment has diagnosis codes. I always keep forgetting to update the URL there. So we are no more using ICD-9, we are using ICD-10. So I'll update it. Okay. So the next type of codes, they are called as taxonomy codes. Like we discussed the other day, taxonomy codes are also called as specialty codes. And these are 9-digit codes. And under HIPAA provisions of healthcare providers, if the given provider is providing any specialty services, they are supposed to declare that using a taxonomy code. Okay, like home health agency will have a 9-digit taxonomy code. Adult daycare will have a 9-digit code, and general hospital has a 9-digit code associated with it. So taxonomy code would define specialty codes or specialty services that are provided by that facility. And after that, you will also see one other type of code called as location code. Location code would represent the location at which service is being provided. Okay, so if the service is being provided at an office, you would use 11 as the code, and if the service is provided at home, you would use 12, and if service is provided at urgent care, you have 20. Likewise, you'll have a list of predefined location codes that needs to be specified as part of the claim to represent where a given service is provided. And these are at a service line level, like here, procedure codes. Again, why do you have office and home and all other locations defined in here? For example, think that somebody got injured at work. So a provider is called in, okay, an ambulance is called in. So where is the service provided by the ambulance? It's provided at the work. And similarly, it can be home, it can be urgent care, it can be ER, it can be inpatient hospital or outpatient hospital.
Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
The next type of data elements you would be seeing on your healthcare claim is modifier codes. So what is modifier codes? Modifier codes may not be applicable in all the cases, but modifier codes would indicate that some specific circumstances has altered a service or a procedure performed, but has not changed the definition or the code. Okay. For example, like I mentioned earlier, every service is represented using a procedure code, right? But think that something has changed, altered the course of procedure, but still you would be using the same procedure code because it would be categorized under the same service. For example, some service is being provided, some person has malignancy, and chemotherapy is prescribed, and it has been administered 2 times. Okay. However, it was decided that the patient might need one other round of chemotherapy. So what would happen? Then you would use the same procedure code that is applicable in all the three cases, which is the procedure code associated with chemotherapy, but you would end up applying a modifier on that line to represent that the same service is being provided more than once. Okay, and sometimes you as a doctor may be providing first round of the service, and for the second round the same doctor is not available, so some other physician was called in. So you would use a different modifier code. So modifier code would represent the change in circumstances associated with the procedure, okay, which needs to be captured as part of the claim. Understood? Any questions? So did we understand what are modifier codes, what are location codes, what are procedure codes, what are diagnosis codes, and what are taxonomy codes? Is it clear? Like we have been discussing since the beginning, there are two types of billing and there are two types of associated claims. So you would also need two different types of claim forms, right? So why do we need two types of claim forms? Because the details you might need for a hospitalization claim may be different from the details you might need to adjudicate a professional claim. So there are two different types of claim forms that are used for the two different types of billing. The first type of claim form is called as CMS 1500 claim form. It is used for professional billing. And second one is called as UB04 claim form, which is used for hospitalization billing. And both of them, they are regulated and maintained by CMS, Center for Medicare and Medicaid Services. And like we discussed during our intro session, CMS is the highest regulatory authority for healthcare in United States, and it is part of Department of Health and Human Services, which is the US Department of Health. Okay, so they manage these claim forms and they keep updating it to add additional details whenever needed. Okay, so this is your CMS 1500 claim form. Can you see that? As you can see on the top right corner, it is a CMS 1500 claim form. So it is used for professional billing, right? And as you can see, this section here is used to capture patient's personal information, like what is the patient's name, patient's address, and other insured's name, and other insured's policy or group number, other health insurance information here, and patient's birth date, patient's relationship to the insured, meaning if the claim is associated with a member and not a subscriber, then you would put in the relation details here, and patient's status, meaning whether he or she is single or married or employed or student or things like that. And if it is employed, then you would also have to provide other details like who is the employer and are you claiming disability or things like that. And so if the patient is not the insured, then you would also have to provide insured's address and insured's demographic details along with the patient's details. Understood? Good. And after that, do you see the horizontal lines here? 1, 2, 3, 4, 5, 6. These are the lines where you would represent services that are provided. So what is the service and what is the CPT or HCPCS code associated with it, and from when till when the service is provided, meaning service start date and service end date. And here is where you would put in location code where the service is being provided, whether it is house or office or things like that, and is it an emergency service. If it is a ER service, then you would provide the details here. And here you would provide the CPT and HCPCS codes. And here modifier codes are provided if they are applicable. And this is the section, as you can see, 1, 2, 3, and 4 here. That is the section where diagnosis code would be listed, meaning what are the ailments associated with this case. And once you have the diagnosis codes listed here, in this section, the E column here, you would be able to link up the diagnosis codes with the procedure codes. How do we do that? If the first diagnosis code is associated with headache and second diagnosis code is associated with stomachache, and if the first service line or procedure here is associated with head MRI, and the second line is associated with stomach X-ray, then you would associate number one diagnosis code, or you would mention number one under the first service line and number two under the second service line. Okay, so that way you are saying that first service is being provided to treat headache, and second service is being provided to treat tummy pain. And this is the place where you would quote the total amount that is being charged, and there's the place where you would specify how much is being paid by the patient. And NPI section would represent the provider identifier. And if there is a rendering provider, you would mention the rendering provider's details here. Okay, and is there anything else? So here you would provide billing provider details, and here you would provide the rendering or referring provider's details. Okay, and should be it. And if there is any prior authorization requirement existing on the claim, then you would mention the prior authorization number here. What is prior authorization? In some cases, as part of the contract between insurance company and the provider, or insurance company and the member, insurance companies would say you would have to take some approval from the insurance company before providing any specialty services. Okay, like if some service requires $500,000, okay, to get that service, then insurance company would want to know about that. Okay, so they would say if the charges associated with the service are going beyond $50,000, then you would have to submit a prior authorization to the insurance company and get their approval and provide the service only if you receive the prior authorization. Otherwise, the claim would not be reimbursed. So in that case, hospitals, they would call the insurance company in advance and they would wait for the approval. And once the prior authorization is received, then they would go ahead with the service. And when submitting the claim, they would include the prior authorization approval number as part of the claim to specify that they have received the prior authorization on that case. Understood? We will discuss that in detail. There are multiple types of prior authorizations. We will go over them in detail when we discuss that concept. And this is your UB04 claim form. And as you can see, is how it is filled. As you can see, the hospital address is filled here, and the patient details are provided here, service lines are provided here, and authorization details are mentioned here, and the other health insurance details are mentioned here, and the subscription details are mentioned here. And what else exists here? Okay, payer details are mentioned here, and plan information is mentioned here. Okay, so they look similar, except that you are supposed to use the right claim form based on the situation. Understood? So again, although there are a variety of medical services, the charges that appear on any given claim usually revolve around particular type of treatment or provider. As a result, claims are categorized into different types, which will often affect the adjudication. So most of the insurance companies, they would again further classify the claims into different categories based on the type of services that are being provided or the type of provider that is providing the service, like primary care physician claims, specialist claims, ER claims, obstetrician or OBG claims, and newborn or wellness claims, radiology claims. Likewise, they would categorize based on the type of provider that is providing the service and the type of service that is being provided also. And the same thing applies for your hospitalization claims. So there would be they would be classified into multiple categories based on the type of provider that is providing the service. There are some high-level rules that needs to be followed when submitting a claim, and these are very generic rules, and again they look silly sometimes, but believe me, there are many claims that get rejected due to this silly reasons. Okay, so let's go over them to make sure that we understand what are the common claim submission rules. Okay, so electronic and paper claims must have correct Medicaid ID or Medicare ID, or they will be rejected. Okay, and you will not believe, but insurance companies, once they get a particular claim form for a particular member, they will store that data for future reference, and that process is called as utilization review. Uh, mm, as part of that process, historic claim information would be retained at the insurance companies. And by law, they should maintain the claim related documentation for 7 years in some cases and 26 years in some other cases. Okay, so by law, insurance companies are supposed to retain the claim information. Okay, so they'll retain this data for long time. Okay, so due to that reason, they would have the members' personal information or demographic information, which would include Medicare and Medicaid IDs. And if the Medicare and Medicaid IDs that are specified as part of the claim doesn't match the details they have in their own database, then obviously they can go ahead and reject it because the Medicare and Medicaid IDs are not correct. And electronic and paper claims must have correct NPI. What is NPI? We have been hearing this term quite often. NPI is nothing but National Provider Identifier, meaning every single provider will have his own provider identification number, and every single provider is registered as part of NPA. Okay, NPR. What is that? National Provider Registry. Once they are registered there, they would get a unique identifier for this provider. So that is mandatory on claim form, and taxonomy code is also mandatory on the claim form. And the provider has specific amount of time from the date of service to submit a claim for that service, and the limit may be different if the provider participates in a network. Okay, so ideally, most of the insurance companies have a limit of 90 days. So claim should be submitted within 90 days after the service is provided. So if it is provided after that, until and unless there is a certain reason, and until and unless they fall under a special category where there is the exclusion, the claim may get rejected because it's not submitted in time. Makes sense? And the typed or computer printed paper claims are never accepted if the info is marked through or white out. So, okay, don't go by this. Usually, you'll not use typed or printed claim forms. Okay, this is a common rule from CMS, which is derived from the CMS portal long back. But you need to use the designated claim forms, which are CMS and UB04 claim, CMS 1500 and UB04 claim forms. But whatever might be the claim form you are using, you can't strike through. If you have a correction that needs to be made, you will take a new form. Otherwise, if you are striking it through, or if you are correcting it, or using a white ink eraser on it, then they would be rejected. And handwritten claims will be rejected and returned to the provider. So they don't accept handwritten claim forms. Make sense? And these are the common reasons why claims get denied or paid less amount when compared with what they might have requested for. Okay, claim has missing information or it was submitted with incorrect information. If the claim is submitted with information that is missing or incorrect information, then it may get pended or it may get denied. So most of the cases, adjusters will correct it by reaching out to the providers and talking to them and getting the consent from the provider to correct it. Okay. However, in some cases, they are supposed to reject it. And provider did not bill according to the contract. Okay. Believe me, in this case, they don't reject it. Okay. This is how it happens in real world. Providers will charge based on their own service charges. Okay. For example, a physician visit. For a physician visit, a physician might be charging $200. However, he's part of a network and he has a signed contract with the insurance company. And as part of the contract, they might have said, I would not charge your patients $200. Instead, I would be charging your patients only $90. However, still, the provider would submit the bill for $200 in most of the cases, okay, because that's their amount associated with that service, okay. But it's insurance company's responsibility, and they would look into the contract because they will have sophisticated claim systems, and they would only reimburse the amount based on the contract between insurance company and the provider. Provider did not obtain the authorization, like we discussed earlier. In some to provide some specialty services, insurance companies would expect the provider to reach out to them in advance and to receive prior authorization before providing a service. However, if the provider has not received the prior authorization and they have submitted a claim without receiving that prior authorization, then there is a good amount of chance that the claim would get rejected. And member was not enrolled on data service. This is a very, very common issue that you would see if you are working for a insurance company's claims department, and particularly if you are working as working in role like a systems analyst or EDI analyst, you would see this quite commonly. Okay, so if the member is not enrolled on the data service, obviously it would get rejected. Claim would get rejected because insurance company is not responsible for the risk during that day, so they will reject it. And member has OHI, the provider was not aware of. Okay, so member has a like we discussed in our earlier example, somebody has mentioned that the health insurance would be the primary insurance in case of an accident. However, the provider has submitted claim to the auto insurance. In that case, auto insurance has captured the details, and they have the details of the primary insurance as part of their policy documentation. So they would reject the claim because they are not the primary insurance as per the patient's consent. So the claim should go to the health insurance. So in that case, they will reject the claim. So it would be mentioned as part of the companion guide. Okay. So when you look into the companion guide, they will say this is the element that is mandatory element. Okay, you should mandatorily fill this in. Okay, there is the other element you don't have to provide, optional. Okay, so in that case you don't have to. Okay, it would be listed. Okay, so there are some common terms associated with claim processing. Okay, what are they? First one, adjudicated claim. Okay, meaning some decision has been made on the claim. Okay, whether it is approved or pended or denied, then it is called as adjudicated claim. Awaiting batch. What does this mean? Claim has been adjudicated and it is awaiting payment processing. Okay, like we discussed, as and when the claim gets adjudicated, payment would not be released immediately. Every company will have their own process of queuing the payments into batches and releasing them at a batch level. So what would they do? They would put the claim into queues, or they will queue the payment, and the payment would be waiting for release along with the batch. So awaiting batch means a claim has been fully processed but awaiting disbursement. Understood? And what is a clean claim? A clean claim is a claim that did not run any validation failures and it is approved without any corrections. And what is an adjusted claim? A claim claims that are corrected due to errors such as incorrect member number or incorrect provider number or overpayment, they are called as adjusted claims. And what are corrected claims? A claim resubmitted by the provider for some reason of corrected or missing information is called as corrected claim. Okay, there is a clear difference between both of them. Okay, if adjuster is correcting, meaning insurance company's representative is correcting after checking with the provider, then it is called as adjusted claim. Okay, however, if the provider is making the correction, or if the claim is sent back to the provider for correction and the correction is being made by the provider, then it is called as corrected claim. Understood? And authorization, we know authorization is a formal approval that is required from the insurance company when providing some specialty services. And there are multiple types of prior authorizations. There is something called as prior authorization. There is something else called as prior certification. There is something else called as prior notification. Okay, we will discuss that as a separate topic. Okay, so far, did you understand what is a adjudicated claim, what is awaiting batch, and what is clean claim, what is adjusted claim, what is corrected claim, and what is authorization? Are you clear with that?
All right, let's test your knowledge. Here's a question for you. Which of the following is not typically a stakeholder in healthcare agile projects? Option A, physicians. Option B, patients. Option C, insurance companies. Option D, automobile manufacturers. Take a moment to think, and when you're ready, choose the correct option. Remember, each choice holds a key to unlocking the answer. Good luck. Type the correct answer in the comments section. Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
Let's move on and let's discuss one other important concept called as authorization. Okay, and we kind of touched it and we kind of understood the high level concept of authorization in our previous session, but in this session we will try to get to the details of it, and we'll try to understand what is authorization and what are different types of authorization and how they are different from each other. Okay, so what is the authorization process? The clinical staff of insurance companies, like nurses, social workers, pharmacy technicians, and prior authorization assistants manage medical care by reviewing requests for future medical services from the provider, and a provider must submit a request to perform certain services, and when a request is granted by the insurance carrier, it is called as authorization. Okay, so let me quickly explain what that means. Usually large insurance companies, they will have their own group of clinical staff, okay, who would include nurses and social workers and clinicians and pharmacy technicians and people like that, who would be employed by the insurance company. And why does insurance company need people like that working on their roles? Okay, they need this clinical staff because in some cases insurance companies will employ their own clinical staff to review cases associated with claims or to review cases associated with certain scenarios. For example, think that some doctor is suggesting a patient to have a surgery. Okay, and this surgery may cost insurance company a lot.
Okay, and so insurance company might want to review the case and understand whether the surgery is appropriate in this case, or surgery is the correct treatment, or surgery is necessary or not. Okay, so just for example, and they might be dealing with prescriptions and prescription drugs for costly medicines, and they might also be employing this clinical staff to review any cases for either the appropriateness of the treatment or efficiency of the treatment to be reviewed. Okay, so that's the reason why insurance companies employ clinical staff at their side. Now, there is a concept called as authorization, and as part of the authorization process, insurance company might include some conditions either in the contract with the members or the contract with the network-based providers to make sure that providers seek the authorization of insurance company in certain cases where insurance company wants to review the treatment that is being proposed. Okay, so in this case, provider will have to submit a formal prior authorization request to the insurance company, providing the details associated with the service and the case details as well, and making sure that he would get the provider would get approval from the insurance company. So this approval that is granted by insurance company to provide a particular type of service is called as authorization. Okay, did we understand what is authorization and why insurance companies would employ clinical staff at their side? Good. So let me read through the slide to make sure that I'm not missing anything. Some services, however, require the use of medical necessity criteria and must be prior authorized before a provider performs the service, and some services do not require a prior authorization but do require the provider to notify the insurance company when they are going to provide the service to the member. When the request or prior authorization has been reviewed by the medical management and found to be medically necessary, then the review process is called utilization management. Okay. So now, the second important concept associated with prior authorization is called as prior notification. So what does that mean? So in case of prior authorization, insurance company expects the provider not to provide the service until the provider receives authorization from the insurance company. However, in some cases, they don't want the provider to wait until the authorization or approval is received, but still they want the provider to notify the insurance company before providing certain types of services. In that case, it is called as prior notification. Make sense?
So, like I mentioned in the beginning, it might be prior authorization requirement might be part of the contract between insured and the member, insurance company and the member, or it might also be part of a contract between insurance company and a network provider. Okay, so good. So that's about prior authorization and prior notification. And like we discussed, prior notification is a process where insurance company need to be notified before a service is being provided. However, they don't have to wait for getting the approval from the insurance company before they can actually provide the service. Okay, and when the request or prior authorization has been reviewed by the medical management, okay, so they will provide the approval after reviewing the case. Okay, this case would be reviewed by the insurance company's clinical team. Sometimes they might be employing the staff that is part of HMOs to review the cases. Okay, sometimes they might be doing this, okay, because they are insurance company's employees. Okay, but you might not need prior authorization in some cases if the services are being provided through HMO. Okay, but again, it varies from contract to contract, because Your company might have certain type of rules and my company might be having different types of rules. It totally depends on how business wants to see that. There is a broader concept called as utilization management. Okay, what is utilization management? Utilization management is a way of utilizing the historical data to take more efficient decisions. Okay, it's a very broad concept actually. So insurance companies might be using historical data of any sort to understand or to come up with decision support and to take better decisions in any given case. Like I said, it's a very broader concept, but prior authorization falls under the concept called as utilization management. And there are some other processes that would be part of utilization management as well, that would be classified as utilization management as well, like encounter management. Okay, we'll look at them in detail in a bit, but for now understand that utilization management is a concept of utilizing historical data to take better decisions in a given case. And in this case, for prior authorization purposes, insurance companies might be using historical data to see whether the service that is being suggested by the doctor is efficient or not. For example, think that in a given case, like we discussed earlier, doctor might have suggested a patient to get surgery performed, right? However, based on review of similar cases, using their historical data at an insurance company level, they might have noticed that surgery might not be more efficient. Instead, chemo might be preferred in a particular stage of malignancy. Just making up an example. So, insurance company might say, okay, based on our review, okay, you can't provide this service because we don't suggest that this is the appropriate service. Okay, and instead we would suggest this particular service. Okay, so then they would deny the prior authorization request. Okay, so insurance companies would be using historical data to review a particular case and take a better decision. We understood what is prior authorization and what is prior notification. So there is one other concept called as prior certification. Okay, and many times you will notice that people use these terms interchangeably. So usually you might notice that people would be using only one term, which is called as prior authorization in all the cases. However, there are three different terms, one being the prior authorization and second one being prior notification, and prior certification is the third one. And they are slightly different from each other, whether it is from the purpose associated with getting the approval or outcome you might be expecting. Okay, so let's look at it in detail. A prior authorization requirement means that insurance company will not pay for the service unless the provider gets permission to provide the service. And sometimes this permission is to ensure that the patient has benefit dollars remaining. Other times it is to ensure that particular kind of service is eligible for payment under the patient's contract. And pre-certification requirement means that the payer must review the medical necessity of a proposed service and provide a certification number before the claim will be paid. And this is often true with elective surgeries. A physician or a nurse with payer must review a physician's order and the medical record to agree that proposed procedure is medically appropriate. So what is the high-level difference between prior authorization and prior certification? Prior authorization is performed to ensure that customer is, or member in this case, is eligible to get the service, meaning whether he has the required dollars in his account or not, or whether the given service that the physician is performing is covered as part of the member's benefits or not. So in this case, in the case of prior authorization, what we are doing is we are reviewing member's account to see that he's eligible to get that particular service. Okay, and in the second case, under pre-certification requirement, we are not focusing more on members' eligibility to get the service, but instead we are focusing more on whether the proposed service is the efficient service based on patient's case or not. So in this case, in the case of prior authorization, like we discussed earlier, insurance companies' clinical team will be reviewing the case to understand whether it is the appropriate service that is being suggested by the physician, or whether the service would be effective based on patient's case or not. So that's the purpose associated with pre-certification. So did we understand the difference between pre-authorization and pre-certification? Good. So there are, again, to do a quick recap, there are three different types of authorization. First one being the prior authorization, second one being the prior certification, and third one is prior notification. And in both prior authorization and certification cases, insurance company expects the physician to get the approval from the insurance company before providing the service. However, in the case of prior notification, insurance company doesn't expect the provider to wait until the approval is received from the insurance company. Instead, he can just notify the insurance company and proceed with the service. And purpose associated with prior authorization to ensure that patient is eligible to get the service through insurance, and purpose associated with prior certification is to ensure that the service that is being proposed by the provider is a appropriate service, and it would be effective based on patient's clinical documentation. Okay, so that's about it. Okay, hoping that you don't have any questions, I'll move on to the next concept, which is called as utilization management. Okay, so what is utilization management? Utilization management is the evaluation of appropriateness, medical need, and efficiency of healthcare services, procedures, and facilities according to established criteria or guidelines and under the provisions of applicable health benefits plan. Typically, it includes new activities or decisions based on analysis of a case. And utilization management describes proactive procedures, including discharge planning, concurrent planning, pre-certification, and clinical case appeals. It also covers proactive processes such as concurrent clinical reviews, peer reviews, and appeals introduced by provider, payer, or patient. Okay, so let me explain what that means. Utilization management, as I mentioned earlier, is a broader concept. And what is the purpose associated with utilization management? Utilization management is a way of looking at historical data and utilizing the clinical capabilities of the insurance company to ensure that a particular service that is being provided is appropriate or not. Okay, and also making sure that we are making right decisions based on the historical data we might be having at our disposal, or capabilities we might be having at our disposal. So it's a very broad concept. So to arrive at a efficient outcome, you are utilizing your capabilities and historical data you might be having at your disposal. Okay. However, there are many other processes that would be falling under utilization management. So as we discussed earlier, pre-certification and prior authorization are part of the concept called as utilization management. However, there are a lot of other concepts which would be falling under the utilization management also, like discharge planning. For example, most of us might have come across this particular clause associated with discharge planning for deliveries. Okay, most of the insurance companies these days suggest that even in the case of C-section, the patient should be discharged within 5 days. Okay, because from their historical view and from their from the data which they might have at their disposal, they might have understood that you don't need a patient to be admitted in a hospital for more than 5 days in that given case. Okay, so similarly, most of the insurance companies, they have their own established ways of or established uh, mm, values associated with discharge planning in a given case. Okay, so discharge planning is one other process that would fall under utilization review. So there is one other concept, for example, called as concurrent planning. So where the insurance company would have a say based on whether two different services can be provided concurrently, or whether how two different services are to be provided in a given case around the same time. Okay, so likewise, and they would also be suggesting, insurance company would also be suggesting peer reviews in some cases, because they might want to understand whether the suggested service by a physician would be efficient in a given case or not, and they have some doubts around it, or they might want to get secondary opinion on that. Okay, so they might suggest peer reviews. So all these concepts where all these processes where insurance company utilizes the capabilities they have at their disposal, which most of the time would be their clinical staff and the analytic systems and data systems which they might have set up at their side. Using them, they would be able to understand whether the suggested service is appropriate or not. Or insurance company would also be able to suggest changes to the service the provider is suggesting. Okay, so that's about utilization management.
Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
So what are the benefits associated with utilization management? So first benefit is cost savings. So obviously that is the major benefit from insurance business perspective. So they don't want to, they don't want providers to abuse insurance benefits. So they want to contain costs by having a say on the services that are being provided. And the second thing would be decreased denials. So they want providers to reach out to the insurance companies upfront. That way, they don't face denied claims. Okay, there are no arguments and appeals around the claims. And third thing, decreased length of stay. Okay, so in a case where patient can be discharged early or ahead of time, insurance companies would be able to decrease length of stay when it is appropriate and appropriate level of care. So patient would be able to get appropriate level of care, but at the same time, they would not be getting the services that were not necessary in a given case. Okay, and decreased healthcare costs. Obviously, at an industry level, you are reducing healthcare costs, and thus you would also be able to contain the premium associated with the policies, because you are able to control the cost. You would be able to control the premiums also, and a timely and efficient discharge, like we discussed, and patient safety, obviously. So there is one other concept called as encounter submission. Okay, so managed care organizations, they submit the encounter data to states and CMS, and they are required to report healthcare services delivered to client enrolled in managed care. Okay, so let me quickly explain it. Okay, so many times regulators might want to review some claims, the data associated with claims from the insurance companies. Okay, it's not specific to healthcare. Even in workers' compensation insurance, there are some ISO regulations that say we would have to submit ISO forms to state. Okay, likewise, in healthcare, so the insurance companies are expected to submit claim-related information to state departments or CMS, or in some cases both. Okay, so this way of submitting claim-related information to the state departments like State Department of Health or HHS or CMS is called as encounter submission. And encounter data files are created electronically and sent in 837 format. So these days, most of these states, they are expecting insurance companies to send this encounter-related data in 837 format or in electronic format. They don't want to accept encounter-related data in paper formats. Okay, so instead, they expect it to be submitted in 837 format. And what is 837 format? That's the EDI transaction associated with healthcare claim. Okay, so what does that mean? That means encounters are also submitted in the same format as healthcare claims. So you don't have to come up with some additional documentation. Okay, so whenever you receive a claim or whenever you submit a claim, you would use the same format to submit encounter data. Okay, to submit the encounter with state departments or CMS. Okay, so you'll be using 837 EDI transaction either to submit the claim, or you would also be utilizing it to utilizing the same format to submit encounter. Okay, and responses are received from the government organizations that receive the encounter. They would be responding with a claim acknowledgement or 277, or they might be responding in using 999 transaction. Also, we'll look into what these are in our later modules. But for now, understand that they would also acknowledge the receiving of encounter using EDI transactions. Why do regulators or why do state departments want this data? Okay, so again, it's a part of or it's process associated with utilization management. So why do they need it? Because they might want to understand either the trends associated with a particular disease, or they might want to review the efficiency of a particular treatment or a drug. Okay, for example, think that if they are receiving more encounters from a particular state, and most of these encounter data suggests that most of the cases are related to some lung-related diseases. Okay, then they would understand that either there is some environmental issue in that area, or some environmental pollution, or some other factor that might be affecting the patients, and that might be creating a prominence of lung-related diseases in that area. So they would be able to step in and they would be able to take appropriate measures, right? And the second thing, which is a very relevant example to what we are seeing these days, is drug abuse, understanding drug abuse and opioid abuse, right? So this is a very prominent and very debatable concept that is circling around news portals these days. So I don't know how many of you know this, but Cigna has come up with a particular regulation at their side. Insurance company, they came out and they told that they would not be, they would be reviewing all the claims associated with opioids, and they would be making sure that there is no abuse related to opioids with their customers. Okay, so again, state departments might be doing the same thing. They might be utilizing this data to understand how many cases are related to a particular drug use, or how many claims are associated with a particular drug use, right? So there is a study that has happened a couple of years back that suggests that the total consumption of opioids in a given year, I think it is back in 2016 or 2017, they found that it would account for 2 bottles of opioids for every person living in the country. Okay, so there was a very widespread abuse. So government would be able to monitor the utilization of a particular drug or prominence of a particular service based on this encounter data. Make sense? So there was a study that has happened, or there was a research that has happened a couple of years back, and due to that research, we came to know that there was a widespread opioid abuse in the states. Opioid is painkillers, okay, that are used to treat severe pain. Okay, so for example, that met with an accident. Okay, so doctors will prescribe them morphine, right? So, but people with minor headaches, they might not need morphine, right?
Yeah.
So people get addicted to opioids. Apart from this, most of the claim-related transactions, okay, they are driven by regulation. Okay, so they are very closely regulated. So what does that mean? So why do we need regulations associated with healthcare claims? Because most of the claims, as we have looked at when we were looking at the claim forms, we understood that the claim would contain demographic information associated with patients, and also the claim would contain patient's personal health information, right? That can be abused. So there is a regulation associated with holding of patient's personal information and transmitting across multiple business stakeholders like hospitals and insurance companies and clearing houses. So as the data gets transmitted and transferred between multiple nodes, that there is a scope for a lot of abuse. So government has come up with, or CMS has come up with some regulation called as HIPAA regulation, right? So we will discuss that in detail when we were discussing the HIE, or Health Information Exchange module. But for now, understand that there is a regulation associated with securing patient's personal information, and that would be applicable for healthcare claims. And particularly if you are using electronic claim forms, okay, like 837 claim form, and if you are receiving the data in electronic format using 835 transaction, or if you are saving the information in a digital format in your own systems, then obviously you would be falling under HIPAA regulation. So this is a very, very serious regulation. And as part of this regulation, companies that hold patient personal information, they are expected to conduct HIPAA audits every year. So every year, these companies are expected to perform audits by hiring external auditors like KPMG, for example, okay, or Deloitte. And also, they are supposed to conduct frequent in-house audits, meaning they should have internal HIPAA auditing department, and they should be auditing they should be performing internal HIPAA audits 2 to 3 times every year to make sure that there is no lapses in your electronic systems, or there is no breaks in your systems that would violate the regulations, violate the HIPAA regulations. Most of the companies, they would purchase and procure software that would perform audits internally. Okay, Nginx Clarity is one tool that most of the companies would utilize in their systems, in their internal systems. They would use this tool to run internal audits, and they would also utilize this tool to understand whether they are the transactions that they are transmitting from their side or receiving from their side are abiding by the HIPAA regulation. So if if you are holding any patient's personal information, as a clearinghouse or as a third-party administrator or as a hospital or as an insurance company, you would fall under HIPAA compliance norms. Okay, we will discuss that in detail. We'll understand the security principle and all the other principles associated with HIPAA when we are discussing health information exchange module. With that, we have completed our second module, which is claims processing.
Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
We'll continue our discussion. However, this would not be around claims process completely. So this module is dedicated towards understanding healthcare EDI transactions. Okay, so how many of you have heard of this term called as EDI? So let me quickly explain it again. So EDI, it stands for electronic data interchange, right? So as the name rightly specifies, it's a way of interchanging the data electronically. So for example, think that you and me wanted to communicate with each other. Okay, how would we do that? We would either use telephone or we would otherwise use email, right? Or maybe some electronic format like Zoom or WebEx or things like that. So if we have to communicate with each other over certain medium in digital format, there should be some contract which both of us would agree upon, right? Meaning if we have to talk to each other using a telephone, we might be using our telephone numbers, right? And if we are using email, we would be using commonly accepted email formats. You might be requiring a email address which is from email address, and you might be requiring a to email address, and you might have to specify subject of the email, and you might also have to specify body or message associated with the email, right? So likewise, every single way of communicating electronically, or every single format that we might be using to communicate electronically, will have their own contracts specified associated with it. Why are these contracts specified? These contracts are specified so that both the parties understand what they are talking about, or both the parties follow some ground rules that they might be using to communicate with each other. So likewise, electronic data interchange is a way of performing system to system electronic business transactions, right? And when I say system to system, you need two computers or two systems to be able to communicate electronically. And is EDI specific to healthcare? Obviously, no. So EDI is used across many other domains. EDI is used in retail environment, and EDI is used in banking environment. EDI is used in healthcare, obviously, and EDI is also used in some insurance-based transactions. So at high level, again, like I mentioned, it's a way of performing system to system business transactions. So each transaction would have some contract defined associated with it. Meaning, if you have to perform a claim submission transaction. There is a predefined format that you would be using that is associated with claim submission. And if you are to submit a payment or submit a claim response, then you would be using 835 transactions. Likewise, if you have to use do benefits enrollment, you would be using 834 transaction. So each one of these transactions, they have some predefined format associated with them. Make sense? Why is this contract required? Hello? You guys are still there, right? You can hear me.
Yes.
Okay, good. So why is this contract required? From our from the knowledge which we have obtained from our previous module, if you have to submit a claim, you require at least 50 to 60 different fields, right? Some of them might be related to member information. Some of them might be related to other health insurance information. Some of them might be related to diagnosis codes, procedure codes. Likewise, you have a lot of information that is required to submit a claim. If you have to use or if you have to submit this details electronically, you should know where to specify each one of those data elements. So maybe in line 2, element 3, you might be specifying member name, and in line 3, element 4, you might be specifying member's address, things like that. So there is a contract that would bind each one of those transactions, and the format that we would be using to submit that particular business transaction would be universally accepted, so that all the trading partners, they can communicate with each other or perform electronic business transactions with each other using the predefined formats. So electronic data interchange is the computer to computer exchange of business in standard formats, and in EDI, information is organized according to specified formats set by both the parties, allowing the hands-off computer transaction that requires no human intervention or keying in on either end. Subsidiary benefits again. The major benefit would be, for example, if I'm a large health insurance company, or maybe I'm a state department of health who might be getting 10,000 claims every day, right? And if I have to receive all those claims in paper format, the next step would be all my adjudication rules or edits are defined in computers, right? Or in electronic or software systems. So what should I do? I would have to manually key in all the data. And like you said, I might have to image the paper claim and store it somewhere. Maybe in some cases, by law, if I have received the claim in paper format, I might have to store the actual paper that I have received. So it's a lot of unnecessary human intervention. And as you reduce the human intervention involved in any process, you have more scope for automating it, and you would have more scope for reducing human errors also, right? Once a system is thoroughly tested, it would not make mistakes because it is designed to function in the same format when similar inputs are provided, and it would return the same outcome or result. So there would be very less scope for human intervention, or sorry, human errors. So if you are using EDI, the most important benefit you might be able to get is reduction of delays, processing delays, right? Because again, going by earlier example, if somebody has to manually submit the claim, for example, provider submits a claim, sends a claim in paper format, insurance company receives it, they would key in the data and image it, and they would run the edits, and they might find some issues with the data that is received or some missing information. And then if they have to go back to the provider again to get the additional information, it would take one other round trip between provider and insurance company. It's the same difference you might see between physical mail and email. If I'm sending an email, you would get it immediately. If I'm sending a mail through FedEx or UPS or USPS, it might take at least one day, even if you are doing it in overnight mail, right? So due to all that benefits, EDI has gained a lot of prominence, and due to the same reason, CMS mandates EDI transactions. Okay, and these days, most of these states, they are also, most of them, they have already moved towards EDI. Most of these states, they have strict regulations that say you should be submitting claim only in EDI format until and unless it falls under some rules or some exclusions where they are allowed to submit the claim in paper format. Okay, so the EDI standards are developed and maintained by Accredited Standards Committee or ASC, and the standard we use for healthcare transactions is EDI X12 standard, and the standards are designed to work across the industry and company boundaries, and the X12 standards specify only format and only the format and data content of e-business transactions. So there is a standards development organization called as Accredited Standards Committee, or ASC in short, and they have come up with this standard called as EDI X12 standard, and which is the format that we would be using in healthcare. And there are multiple transactions associated with multiple business transactions you might be performing in real time. We will discuss that in a bit. Okay, so what benefits you would be getting by using EDI? First thing, like I mentioned earlier, reduced cycle time. So there would be no transition delay, and better inventory management. You don't have to maintain the paper. So you would be able to use same NAS drive or same systems memory or systems data drives to store millions of data in the electronic systems, and you don't have to worry about inventory management these days. If you are using software systems, there are a lot of document management softwares which are very efficient at managing and retrieving and providing options to query the documents also. So you are better off storing them in electronic format, and increased productivity. Like I said, you don't have to key in the data, you don't have to image it. If you are receiving it in electronic format, it can directly get queued up for batch processing, and all the adjudication steps would run, and immediately you would be receiving a acknowledgement, or immediately you might be receiving errors that might have occurred while adjudicating claim. So there would be a very huge productivity increase, and it would reduce costs also. You don't need human intervention. Once you have invested in systems, you should be able to use the same systems for a lot of years. So it would reduce a lot of cost, and accuracy would be also improved, and improved business relationships. If your turnaround time for a transaction is quick, your business relations will also improve, and you would be able to process more transactions in less time. And customer service would also be enhanced, because if the data is stored in electronic format, you would be able to get real-time status on those transactions very easily. For example, if somebody has submitted a claim, you would be immediately getting a acknowledgement in 999 transaction, or a claim acknowledgement transaction. You would be receiving it immediately, almost within next couple of minutes. And increased sales. Okay, again, this is not so related. It might be a secondary benefit. And minimized paper usage, obviously, and increased cash flow. As your turnaround time increases, you would have the capability of taking in more business and processing more business transactions in the same amount of time. So that way, your cash flow would also increase. Okay, and again, these transactions are replacement of paper forms, right? So, like we discussed in claims case, you should be using CMS 1500 or UB04 claim forms, and these would be replaced by a 837 business transaction or 837 EDI transaction. So likewise, most of the other transactions, they are also, or they would also be replacing existing physical forms. Okay, so our paper forms. And again, these transactions are 100% equal to paper claim forms. For example, we will take example of 837 and 835 transactions, and we have already seen how physical claim forms would look like. So now, when we start discussing the EDI transactions, when we take the example of 837 transaction and go through it, you will understand that all the details or all the elements or element groups which we have discussed in our earlier module, you would be able to see the same elements in your 837 transaction also. Okay, so so healthcare claim would be represented by a EDI 837 transaction, and payment and remittance would be represented by 835 transaction, and invoice is represented using 810 transaction. Invoice we don't use in healthcare, we use it in retail, and purchase order is a retail transaction. Again, it would be represented using a EDI 850 transaction, and again we have those transactions here, retail transactions mentioned in this slide, just to give you an understanding that EDI is not specific to healthcare, and it is used in other domains also. Okay, so HIPAA mandates EDI transactions, and the rules are based on electronic data interchange standards, which allow for the exchange of information from computer to computer without human involvement. We already discussed that. And okay, so what is a transaction? We keep hearing this term called as transaction. So what does transaction mean? So transaction is nothing but a electronic business document, and under HIPAA, a handful of standardized transactions would replace hundreds of proprietary non-standard transactions currently in use. Okay, and again, pay some attention here. Remember, we discussed what is standard and what is non-standard format, right? When we were discussing clearinghouses, we understood that clearinghouses are the intermediaries, or third-party organizations that would help providers to be able to convert non-standard data into standard format so that it can be submitted to the payer. And when the payer responds with a standard response or standard transaction representing a response, they would be able to convert it into non-standard or standard that is understood by your provider, and send the data so that they can review it. Make sense? So it's the same thing. Transaction is a electronic business document, and a bunch of EDI transactions would be replacing existing large number of paper forms. Okay, and for example, like we discussed, HCFA, we used to call it as HCFA 1500 earlier. After that, it is renamed as CMS 1500. So CMS 1500 form would be replaced by EDI X12 837 form. And each of these HIPAA transactions has a name, a number, and a business or administrative use. So what is the name? Claim submission is the name. And what is the number? 837 is the number. And what is the purpose associated with it? It is used for submitting the claim or submitting an encounter. So likewise, each one of those transactions, they would have a name, number, and some business purpose associated with them. And let's take a quick look at the commonly used EDI transactions in healthcare. So first one, as we already know, is EDI X12 837 transaction, and it is used for submitting a claim or it is also used for encounter submission like we discussed earlier. And eligibility inquiry and response. So if you are a provider and if you want to check the eligibility of a particular patient, or if you want to do benefits inquiry, you would be using 270 transaction, and the payer would be responding using a 271 transaction. Make sense? And if you have to understand the status of a claim, so for example, a third-party administrator has submitted a claim, and they couple of days back, and they want to understand what is the current status of the claim. They would be submitting 276 transaction, and they would be getting a response as using a 277 transaction. And referrals and prior authorizations are submitted using 278 transaction. You know what is a referral, right? By now,
Yeah.
you should be aware of it. Okay. And we know what is authorization or prior authorization from our earlier class. And healthcare payment and remittance advice. So like I mentioned earlier, response for a claim is received using a 835 transaction, and usually this 835 transaction is called as explanation of benefits or remittance advice. So when you go to a provider to get some services and you use your health insurance, after a couple of days after getting the service, your insurance company would send you a letter that explains what services are provided and how much the provider has charged and how much the insurance company has paid and what are the discounts that are applied, and finally what is patient's responsibility. So this document is called as explanation of benefits, and usually providers will also get the same document, but in that case it is called as remittance advice. It's the same document with the same details, but if the document is sent to a member, then it is called as explanation of benefits, and if the document is sent to a provider, then it is called as remittance advice. Understood? And usually remittance advice is followed by a payment. So if I have to give you some real-time explanation of how it would work, usually provider would submit the 837 transaction, and insurance company will load the 837 file into their system, and they would map the data fields, or system would be automatically mapping the data fields, and they would load it into adjudication or CMS softwares. And once they data is loaded, they would be running all the basic and proprietary edits like we discussed earlier, and they would take a adjudication decision, and if it is a decision to make a payment, immediately a 835 transaction would be sent to the business partner or banking partner of the insurance company. For example, JP Morgan Chase, or BNY Mellon, or Wells Fargo, or there are many large banking organizations who does that. So what would they do? They will take this 835 transaction that is received by the received from the insurance company, and they would create the documents on behalf of the insurance company, and they will send it to the provider and also the member. And along with it, based on the type of payment that needs to be made, they might be either sending checks, or they might be sending EFTs, or they might be sending any other mode of electronic payments. Make sense?
What is EOP? I know EOB is explanation of benefits. What is EOP?
Yeah, again, people use this term, these terms crazily across industries. Actually, somebody, they would call it as EOP. EOP is explanation of payment. It's nothing but a remittance of advice, and somebody would call it as EOR, explanation of review, they call it. Okay, so at the end, it's the same thing. EOB, EOP, EOR, it's the same thing. Understood? And again, some of these terms vary from domain or type of insurance that is involved. So usually in healthcare, they would either use the term EOB, RA, or they might also use the term called as EOP, right? And usually in property and casualty insurance, they might be using a different term. They would call it as EOR. Understood?
Okay. So RA
So
is
these
a
are
good.
notations, yeah, industry notations actually. However, if you use one term, it is commonly understood across all the industries. So if you say EOR, everybody will understand. They might be calling it as EOP, but they would still understand what a EOR or EOP is. Make sense?
Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
You need to know the transaction names. Okay, again, I would strongly suggest at least remember this 5 or 6 transactions. You don't have to remember anything beyond it. Okay, and you would have to be familiar with at least the format associated with EDI. Okay, and get yourselves familiar with at least one transaction in detail to understand how it looks like and how the data is saved. Okay, you don't have to remember everything. And again, the purpose of this module and how we would be understanding it or discussing it here is I will take example of one transaction, which is 837 transaction, and I would explain the high level format associated with the transaction, and I would explain you how to use documents called as implementation guides and TR3 documents or companion guides to understand a document. Okay, meaning there is a guide that would tell you how to look at a document. Okay, we would be reviewing it, we'll be understanding the format, and we'll also understand how to use that guide. Okay, so that tomorrow if you have to deal with one other transaction, you don't have to start it all over again. So if you have the guide, you would be able to understand it. Make sense? So finally, there is a proposed transaction as well. It is 275 transaction, and it is used for submitting additional attachments or documents. And I have been teaching this module since at least 2012, and this has been proposed since then. Okay, it has still not, it is still not yet materialized. Okay, so this is one example of how EDI is used. Okay, for example, take the example of benefits enrollment. How many of you get your insurance through your employer? Do you know, or have you ever got your insurance through your employment? Okay, so if you have got insurance through your employment, you would be aware of this process. Usually there would be a intermediary enrollment agency, okay, like employee benefits or some company like that. So what will they do? Your employer will not be enrolling every single person through a paper request. What will they do? They will ask you to submit all your details with that third party or intermediary company. Or if you are a big company, your HR people, they may be filling in all the details on your behalf. And what will they do? This intermediate company, they will, or benefits management company, they will submit a EDI transaction called as 834 transaction. Make sense? So it is used for benefits enrollment, enrolling a new employee with a health plan. Okay, so once the 834 transaction is submitted, insurance company will load the data into their systems, and they will wait for the next transaction, which is premium payment, right? Obviously, if you have to enroll a new employee, you'll have to pay the premium for that person. So again, this would happen through 820 transaction. Usually, this intermediary benefits enrollment companies, they would accept invoices from the human resources departments, and what they will do, they will have some tie-ups with some financial organizations or banks, and they would route the transaction, which is a 820 transaction, through their bank, and they would get the payment made to insurance company. And once the premium payment is made, insurance company will enroll the member, and they will send your insurance ID cards. Do you understand that? So there is no human intervention anywhere. You submit 834 transaction, you make premium payment using 820 transaction, and member will be automatically enrolled. Does that make sense? Standard format developed by ASC X12 for healthcare claims submission through electronic data interchange is called as 837 transaction, and a successful EDI transmission requires a health plan to have strong working relationship with their trading partners. And prior to each implementation, it is essential that each health plan and its trading partners have a clear and common understanding on contents of the claim data. So again, you would be able to perform these transactions electronically only if both the parties understand and agree upon the guidelines or agree upon how the transaction should be submitted. So, like I mentioned in the beginning, you should agree upon a contract, right? So if you have to submit the transaction in electronic format, particularly the claim transaction, you'll have to agree with your business partner that claim submission would be made in 837 format. And the version of the 837 transaction we would be using is either 4010 or 5010. But after 2011 and 2012, most of the companies, they have upgraded their systems to 5010. These days, most of them, they are not using 4010. And claims should contain provider and member identifiers. So the claim should contain provider identifiers, like we discussed earlier. You'll have to mention NPI details or taxonomy details, or providers social security or FIN codes if needed. And also member identifiers are mandatory. As we have seen in our CMS 1500 and UB04 claim forms, there is a section where it would ask for members social security number and members Medicare and Medicaid IDs. Likewise, even in 837 electronic transactions, you would have to mandatorily submit provider and members identifier details, and you should validate membership data submitted with the claims. So once the data is submitted, payer has to validate that the identifiers that are provided are valid. Okay, so how would they know that? Particularly with providers. With providers, they have a national registry of providers, and they would be validating the providers' details in NPI database. Because these days, most of the organizations, whether it is provider-based organizations or payer-based organizations, and there are a lot of clearing houses. Okay, and again, when I say clearing houses, these are large intermediary organizations who have the revenues in hundreds of $1 million or $1 billion. So there are a lot of opportunities with these companies. And one other area where I noticed from my past experience that having EDI knowledge would help is with state projects. Okay, so most of these states, like I mentioned earlier, they mandate EDI. So states are accepting either encounter data or claims also in EDI format. So who would submit claims to the state departments? Okay, for example, think that there is a member who is eligible for Medicaid benefits, and he has mentioned his Medicaid details as part of the insurance claim. So what would the insurance companies do? They would reimburse it, and they would pass in the secondary claim. They would pass in secondary claim to state departments so that they can get reimbursements from the Department of State. Okay, so state departments, most of these state departments, they will get large number of EDI transactions every day. So they are employing support staff, and they are employing claims analysts, and they are employing claims business analysts who have EDI knowledge. And I did not notice it this year, but in past 2 or 3 years, I have seen at least a couple of my previous students landing in jobs with either companies like Deloitte or KPMG, or directly with state, where they are working on state-based projects that would require analysis on EDI documents. So how does inbound 837 process work? And this is a very common term. Why do we call it as 837 inbound process? We call it as 837 inbound process because the transaction is inbound to a insurance company. And like we discussed in the beginning, most of these transactions would happen at an insurance company level. So we would try to understand these transactions, or we would try to represent these transactions from a payer's perspective. So from an insurance company's perspective, 837 is a inbound transaction and 835 is a outbound transaction. So that's the reason why we call it as 837 inbound process. And what are the high level steps associated with 837 inbound process? So first thing, when the EDI 837 file is received by insurance company, they will read the file that would contain 837 data, and they meaning the system here. The system will automatically map the fields inside the EDI file with the fields in their systems or fields in their database, and they will write the data to an intermediate file, or the file that is understood in their company's internal systems, or format that is understood by their internal systems. This format is also called as canonical format. Whenever you hear a term called as canonical format, that means it is a intermediate format that is understood across the company. Okay, not understood external to the company, but it is understood in their internal systems. And once they write the claim to the intermediate work file, so they would report on errors and run controls, meaning you would run the basic edits and proprietary edits using your claim management software, and you will read the intermediate work file, and if everything looks good, you will generate the claim numbers, and you would generate acknowledgements associated with the claim and send the acknowledgement to your business partners. Okay, so in this case, it is providers. Does that make sense? Did you understand it? So the file would be loaded into the system, and fields would be mapped into the internal database or system fields, and a intermediate file or file that is represented in the company's canonical format would be created, and that file would be used to run basic and proprietary edits. And once everything is validated, claim numbers would be generated and claim acknowledgements would be sent to your business partners. Again, why do we use EDI? We use EDI because it is universally understood. For example, think that you are a clearinghouse or you are a provider, okay, and you get patients from Cigna Insurance, and also you would get it from United Healthcare. So you don't want to have two different formats to submit claims to Cigna and also to United Healthcare. So it would be better if you have one format that is understood by all the business partners. So that's the reason why we have come up with the universally accepted format called as EDI X12 format. However, okay, it is a very stringent format. So we will see that in this module. Okay, let me show you how this is how it looks like. This is your EDI 837 format. Is it easy to understand? No. Okay, so usually companies would change it into either JSON or XML formats. Okay, so that XML or JSON formats are easily understood by software systems. So they would change it into XML or JSON format so that it is easily understood. Again, like I mentioned in the beginning, you don't have to remember every single element and every single segment and loop inside your EDI transaction. So that is not at all needed. So if you understand the high level format, you would be able to use the companion guides and implementation guides, which are documents that are support documents that would explain the format and position and representation of the data elements inside the EDI transactions. So you would be able to use companion guide to understand a particular transaction. Every transaction will have its own guide, and you would also be able to use implementation guide to understand any additional details. Why do you need two different guides? Companion guide is a document. EDI is a universally accepted document, right? So that is a document published by CMS. So that is universally accepted. So that provides most of the details. However, there are some buffer elements. Okay, so there are some buffer codes. For example, think that some companies might use A, B, C, and D to represent primary, secondary, and tertiary insurances. Okay, or insurers. So, however, some companies may be using 0, 1, 2, and 3. Right? So to get some additional details which are specific to the company, you can use that company's implementation guides. So they don't contradict each other. Companion guide and implementation guide, both of them, they would hold the same information mostly. However, implementation guide may include some additional details and guidelines which are specific to that particular insurance company. Make sense?
All right, let's test your knowledge. Here's a question for you. Which Agile practice is particularly useful for capturing healthcare user needs? Option A, user stories. Option B, Gantt charts. Option C, waterfall planning. Option D, Big Bang testing. Take a moment to think, and when you're ready, choose the correct option. Remember, each choice holds a key to unlocking the answer. Good luck. Type the correct answer in the comment section. Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
You might hear, like I mentioned earlier, depending on where you are working or the type of company you are working or the industry where you might be working in, some terms might differ. Okay, however, these terms, they get used interchangeably. Okay, they have the same meaning, but these are some common terms which might represent the same meaning, but used differently based on where you are working in or based on the context. So first thing, claim and invoice. We know what is a claim, right? Claim is a formal request that is submitted by the provider to the insurance company to get reimbursed for the services they have provided to the insured, right? So in some cases, we use the term invoice to represent claim. Okay, So invoice and claim, they are same from insurance perspective. And service line and claim line. So when you try to get a service, okay, for example, as a provider, when you are submitting a claim, you might be submitting a claim that is associated with a couple of services that are provided to a member, right? So when I say a couple of services, it might be one service or it might be more than one service depending on the scenario. So if there is more than one service being provided, for example, if somebody got sick and they got hospitalized, there might be some blood work that gets done, or there might be some room service that is being provided. There might be IV fluids that are provided. There might be some emergency service that is provided. So when the provider or the ER submits the claim, they would include every single service that is provided as part of the treatment inside your claim. So when I say every single service, each single independent service that is provided as part of the treatment is called as service line. Understood? Okay, so in our earlier example, room service is a service line, and IV units that are provided, they are one other service unit, and diagnosis test is a service unit. So, sorry, service line. So, service line can also be called as claim line. Okay, so when you hear the term service line or claim line, it represents the same thing. Understood? And adjustment, okay, or replacement. So commonly we use the term called as replacement. So adjustment is, we call it as adjustment when the adjuster or claims analyst would make a change to the claim to get it adjudicated. Meaning, for example, the provider might have asked for $200, but the contract says you can only reimburse $96. So adjuster would change the amount on the claim and or adjust the amount on the claim, and adjuster might adjudicate the claim. So in that case, it is called as adjustment. But if the provider submits a claim and after submitting the claim, they have noticed that they have missed something or they have misrepresented something, some information on the claim, and they wanted to change it from their side. So they want to resubmit the same claim. Okay. Then in that case, it is usually called as replacement. Okay. However, commonly we use the same term called as adjustment if adjuster is making the change, or even if the provider is asking for a change. So in both cases, you can call it as adjustment also. So the terms get used interchangeably. And voided or cancelled claim. So if the provider reaches out to the insurance company to void a previously submitted claim, then it is called as voided claim. Or sometimes it can also be called as cancelled claim, right? Voided or cancelled claim. However, it can also be called as adjustment, or some in Medicaid terms, or in property and casualty insurance terms, they would sometimes call it as adjustment also. So it depends on the context. And healthcare claim adjustment in normal terms, like I mentioned, is the change that is performed by the adjuster or the insurance company based on some information they might be having at their side. So usually they do that to get the claim adjudicated. So there is no term in Medicaid terms. So in this case, if adjuster is making a change, you will commonly call as adjustment. And subscriber. A subscriber is the person who holds the subscription, or the person who holds the enrollment to the plan is called as a subscriber. Understood? Is it clear? And however, you can also use the term recipient or beneficiary for the same role. Okay, and billing or pay to provider. The provider who is submitting the claim is called as billing or pay to provider, and who is what is that? Pay to provider and referring provider. So referring provider is the provider who has referred the patient. So usually the first level provider would be called as referring provider, and the last provider in the chain of treatments that are being provided is usually called as billing provider, because billing provider would be submitting the claim. And again, let me know if I'm going at a faster pace. It's only because some of these concepts we have already discussed. So I want to stick to the schedule so that we can get the domain topics completed in time, and we can spend good amount of time working on BA concepts. These are the common transactions covered as part of HIPAA 5010 transaction set associated with healthcare. Okay, so some of them, they would happen before the treatment, and some of them, they might happen as part of the treatment, and some of them, they are part of Medicare. So there are two transactions that would happen or that would be performed before the treatment is provided. So what are the? Eligibility verification and authorization or referral. So the eligibility verification transaction would happen when a patient is visiting the provider for the first time, and he or she is not registered with the hospital. So what would they do? They will tender their insurance card or insurance details, and provider will trigger this transaction to check whether the given patient is enrolled or not, or if he or she is enrolled, does he have the required benefits to be able to get the treatment. Understood? Is it clear? And the second one is called as authorization or referral transaction. We know what is prior authorization, right? If hospital has to submit a prior authorization request to the insurance company, they will use the transaction called as 278 transaction to perform that. And the next important transactions which are associated with healthcare claims are remittance advice or explanation of benefits and remittance advice and claim status. So we know what is explanation of benefits. Explanation of benefits is the transaction that is submitted as a response to the adjudicated claim. So when the claim is submitted using 837 transaction, insurance company will receive the claim, they will process it, and if the decision associated with or if the claim is adjudicated, then they would usually send out a EOB or remittance advice. Okay, and like I mentioned earlier, both of them, they would contain the same details, and one of them would be going to the provider and second one would be going to the insured. So we would use a transaction called as 835 transaction to perform remittances and claim status. So sometimes insurance company would usually process the claims in batches. So we will discuss that workflow from a practical perspective once we are done with this module. But understand that usually insurance companies do not process the claims in real time. So they will receive the claim and they would automate the process to run the claim through all the required validations. However, they would not make the payments and they would not send the responses immediately. So what would they do instead? They would queue the adjudicated claims into batches. So batches would be processed maybe end of the day or once in 3 days or once in a week based on how large your company is. So before they get the response from the insurance company, if the hospital wants to check on the status of the claim, you would usually submit 276 transaction, and the response for a 276 transaction would be received using a 277 transaction. Understood? Remittance advice. So when a claim gets submitted to the insurance company, so as part of the claim life cycle, claim would be processed or handled and a decision would be made on the claim. So once the decision is made on the claim, the decision would be usually a approval of the claim or adjustment to the claim, approval with adjustment, or denial of the claim, or in some cases, putting the claim in pending status. Okay, so whatever might be the decision associated with the claim, insurance companies will send the details associated with the decision in a formal explanation of benefits or remittance advice format. So if you have ever visited a hospital with your insurance, a couple of days after you have received the service from the hospital, your insurance company would send a paper with the details associated with the treatments that are being provided and how much they charge, how much the hospital has charged for the service, and how much discounts have been applied to the particular service, and how much has been reimbursed for the service, and how much is the responsibility of the patient if patient has to pay some amount out of his or her own pocket. So all those details would be put in a formal document, and they would be sending that to the insured. Likewise, they would send the same details to hospitals also, the provider who has submitted the claim. So provider would also receive the same details. These formal documents that are sent as part of the process are called as explanation of benefits. So if the insured is receiving the document detailing the services and claim details, then that is called as explanation of benefits. With the same details, if the document is sent to hospital, then it is called as remittance advice. Okay, so that's about remittance advice and explanation of benefits. Okay, so same transaction would be used in Kshitesh. So authorization or certification, you would still use the same transaction, 278. Okay, but depending on the process, it would be handled as a prior authorization or re-certification. That's about claim status transaction. And after that, we have some managed care transactions. So we know what is managed care plan. And there are some transactions that are associated with managed care. What are they? First thing is called as enrollment. Like we discussed in our earlier example, if you have to enroll a new patient, a new employee, or a new member into a existing plan, you would be submitting a enrollment transaction, which is submitted using 834. And if premium has to be paid, you'll be using 820 transaction. And if encounter has to be submitted, you would be using 837 transaction. But remember, like I mentioned earlier, encounter and claim are both submitted using the same format and using the same forms, even if you are submitting it using a physical document. So that would be 837 again. Understood? If we go through, so we would be able to go through the workflow between your provider and the payer using the same list of transactions. Okay, so if a patient is admitted into a hospital, then first step as part of the pre-registration would be eligibility inquiry, and a 270 transaction would be submitted by the provider, and the payer would respond using a 271 transaction, and utilization review, if required or if applicable, like pre-certification, would be submitted using 278 transaction, and pre-certification response would be received in 278 transaction. And this might answer your question, Kshitesh. And claim is submitted once the patient is discharged. Claim would be submitted using a encounter or claim transaction, which is represented using 837. And status on a claim would be requested using 276 transaction, and response would be received in 277 transaction. And once the adjudication happens, payer would send a remittance advice or explanation of benefits to the provider, and at the same time, they would initiate the payment through 835 transaction through their bank. So let me add some additional details around 835. So 835 transaction is about remittance advice, right? So you would have to send a formal document to your provider or the member explaining the details of the claim adjudication. Okay, however, the same transaction is used for payments also. So how would that happen? These days, or most of it has been happening since at least past couple of years, where most of the large insurance companies, they will tie up with some third-party financial organizations, okay, usually banks like JPMC or Wells Fargo or BNY Mellon. There are a bunch of banks who are into that business. So what would they do? They will have their own healthcare insurance support wings or managed care support wings. And what would they do? They will sign contracts with insurance companies, and as part of the contract, they will take over the whole payment process or EOB plus payment process. So instead of insurance company printing those explanation of benefits and sending them to the patients, they would delegate it to this third-party vendors. So what would they do? They will charge amount per transaction, and they will receive 835 transaction from insurance company, and they will read through the transaction, and they will process the transaction, and they will generate explanation of benefits, and they will send the explanation of benefits and remittance advisors in physical mail to both provider and the insured. And at the same time, they will also look at the preferences from the provider, and meaning payment preferences. So in what format they might expect the payment, and they will get the details, and based on that, they will review the 835 transaction, and they would generate payments. So they would issue checks on behalf of the insurance company also. Does that make sense? So that is the reason why you see a bank in between. And again, like we discussed while we were discussing the physical claim forms, even in EDI transactions, there is a segregation. Okay, meaning based on the type of billing, whether it is professional billing or institutional billing or dental billing, based on the type of billing or type of service that is being provided or type of provider, you would be picking a particular 837 transaction. Okay, so if you are a provider that has provided hospitalization services, then you would pick 837 I transaction or 837 institutional transaction. And if you are a physician and you have provided outpatient services to a patient, then you'll pick the 837 P transaction. And if you are a dentist, you will pick up 837 D transaction and submit it. So there are three different types of 837 transactions. Okay, don't get scared looking at this document. So before we discuss this document, let's spend good amount of time trying to understand the format associated with EDI transactions.
Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
So EDI document is a hierarchical document. Okay, so what does hierarchical document mean? Let me explain it. Okay, so think that, so what are we trying to represent using a EDI transaction? We are trying to represent some data associated with business functions, right? So it might be a claim, or it might be a explanation of benefit, or it might be a claim status, whatever it might be. In all the cases, you are representing some data associated with the business transaction, right? So usually these transactions are hierarchical in nature. So if I have to take the example of how a hierarchical transaction would look like. For example, think that we want to represent a family tree, or some ancestry details as part of a hierarchical document. How would you represent it? So at the root level, say for example, at the root level, you have some person, okay, person A, okay, and this person A, he has two sons, for example, okay. One is person 1 and person 2, right? And this person 1, he has two kids again, okay, a daughter who is person S, and a son who is person K, for example, okay. And at the same time, person 2 has two more kids, okay, for example, small a, small b. Understood? So if you have to represent a family tree like this, or some data associated with a family, you have data represented at multiple layers, okay, or there is some hierarchy we are following here. At the root level, there is a grandparent, and under the grandparent, there are siblings, and under the siblings, there are grandkids, right? So this is level 1 in the hierarchy, and this is level 2 in the hierarchy, and this is level 3. Are you following so far? So also there is a one-to-many relationship between the parent and children. Okay, so one parent may have more than one children. So here, this parent has two children, and this guy here, he has two children, and this guy here, he has two children. Make sense? So same thing applies to most of the data elements. Okay, so not only specific to EDI, or not only specific to health insurance or healthcare, but any data you might want to represent would be ideally represented in a hierarchical data layer format. Okay, so examples would be XML and JSON and HTML. Okay, and also EDI. Make sense? Is it clear so far? So all our EDI transactions, they carry hierarchical data. Okay, and EDI transactions are also represented in multiple layer, or multiple what do you call it, multiple data element layer formats. Okay, so let me quickly clear up the board, and okay, we will pick up the example of a EDI document. Okay, so are you still able to see the EDI document? Okay, let's forget about it. Okay, so all of our transactions, okay, at a skeleton level, EDI transactions would start with a interchange header. Okay, so it is represented using ISA element. Okay, so there would be a interchange header, and it would be having a interchange footer. Okay, so IEA. Okay, and before I get to details of this, okay, like we discussed about hierarchical data transactions. So going by the earlier example, let me see if I can bring that up. Okay, so in this case, this layer or layer 1 would start here and it would end here, right? And this second layer is starting here and ending here. And also it starts here in this layer and it would end here. And at the same time, the third layer starts here and maybe ends here. So ideally to be able to represent your hierarchy in your data elements, you would use start and end elements to represent where the particular layer starts and where it ends. Okay, so for example, if I have to bring up details associated with parent here. Okay, so for example, parent is parent, and you can say the parent layer starts here and parent layer ends here. Okay, and you can say child 1, okay, starts here and child 1 ends here. Okay, to represent the hierarchy or layer of the elements. Okay, so child 1 ends here, and inside in between this, okay, if the child 1 has grandchildren, for example, okay, you can represent all of them here. And if the child 1's name needs to be represented, you can add the name here. Okay, and child 1's last name can be represented here. So there is a way of grouping all the data elements associated with the child 1 in this layer, and there is a way to represent all the details associated with the parent element in here. Okay, so that is how hierarchical transactions are usually represented. So even in our EDI transactions, you will start the transaction with a ISA segment. Okay, so what is a ISA segment? ISA segment represents interchange. IIIS represents interchange segment. Okay, or interchange start. Okay, and IEA represents interchange end. Okay, and again these are notations, they don't carry much of a meaning. Okay, these are just notations. So when you see any EDI transaction, it usually starts with ISA and it would usually end with IEA. Make sense? So that means the interchange that is happening between two business partners is starting with this and it is ending with this. It's like a document start and document end. In a interchange, for example, think that I'm a big clearinghouse, okay, and I would deal with 10 insurance companies. Make sense? So, for example, I'm a big clearinghouse, and I would support hundreds of providers in a given state, and I would deal with tens of insurance companies also. So, what would I do? I may have to submit 10 837 transactions to Cigna and 10 835 transactions to Cigna and 5 transactions to United Healthcare and 5 transactions to Aetna, for example. Okay, so let's take the example here. Okay, so I do business with Cigna and I do business with Aetna and I do business with United Healthcare, for example, okay, or Humana maybe, okay. And there are tens of transactions, or at least 6 or 7 transactions, which we have discussed, that are prominent, okay. So there might be a 837 transaction, right? And there might be 270 transactions, right? And there might be 2 28 transaction. Okay, let's leave it there so that we don't complicate it too much. Okay, so in this case, to Cigna, I might have to submit 5837s and 3270s and 1278, and to Aetna, I might submit 812, for example, and 123, right? So in total, I'm submitting around how many? 9 and 10, 20, and 26, right? So I'm submitting 26 transactions in a given day, right? So, but these 20 different transactions would go to 3 different business partners, right? So I can segregate those business partners and I can send all the transactions associated with all my business partners in the same document. In one document, I can send all the transactions. So each one of them would be represented using a functional group. Okay, so it is represented using group start and group end, right? And likewise, you'll have the next functional group, group start, and so likewise, you can have more than one functional groups represented as part of the same document. And again, each functional group represents a business partner, right? So this might be this might represent all the transactions associated with Cigna, and this might represent all the transactions associated with Aetna. And to Cigna, I can submit more than one transaction, and each transaction would be represented using segments. Okay, so I'll call it S, T, and S, E. Okay, and there might be again one more S, T, and S. Understood? So this might be a 837, and this might be 270. Okay, so if you have noticed so far, all these, is there a way to pick up different colors? So all these are going to Cigna, and all these are going to all the segments or transactions in between. This are going to Aetna, and likewise, you can put in more than one transaction going to Cigna in between this functional group. Is it making sense? At high level, are you understanding the structure of the EDI document? So EDI systems will take care of it. Okay, they will pick up the identifier associated with the business partner, which would be part of this segment, and it will pick up only between this and send it to Cigna, and it will pick up between this and send it to Aetna. Okay, systems will do that. The EDI systems will take care of it. There are multiple tools actually, multiple tools. Nginx have a couple of products, and Nuance Communications, they have certain products, and 3M have products. So there are many products available for that. And some companies, they will have their own custom solutions also. You will not go through all this. Okay, you will not be submitting transactions. That is done by your billing office. That might be done by real business people will do that. Okay, we are business analysts, so we will deal with business requirements. So you'll have to understand it, but you will not do
using
it. Yeah, you'll not be using it. Okay, but if you are if you would be working as a technical analyst or a systems business analyst, you might be reviewing it for any issues or for any debugging purposes, okay, but you will not deal with EDI systems in real time until and unless you are working on developing one of those systems. Each line you see here, okay, so each line you see here, like GS and ST and SC, each one of them, they are again called as detailed segments, okay. So each line is called as a detailed segment, and in between here ST and SC, you will put in, if it is 837 transaction, you will follow the format associated with the 837 transaction and include all the detailed segments that are required for 837. And if it is a 270 transaction, you'll include all the detailed segments associated with 270 transaction. And every single line is called as a detailed segment. Understood? And every line in a EDI document would end with a tilde symbol, okay? A symbol like this, which you see on your computer as first character on your special characters line on your keyboard. So this is called as tilde. Okay, tilde is the line delimiter for every single line in a EDI document. Understood? And for example, think that there is a line that represents provider details, okay, and inside that you have to represent the provider's first name, last name, and title and all other stuff, for example, okay. And in the next line you might have to represent the member's information, and it would include member's first name, last name, and phone number, title, and prefix, suffix, all those details. So this is a detailed segment that represents provider information, and this is our provider's name information. And the second one is a detailed segment that represents the patient's name information. Understood? And each line here would be delimited by a tilde. Okay. And inside each line, for example, and again, like I mentioned earlier, you might have a detailed segment that represents provider's name information. And inside the name information, name has multiple parts, right? The name has a first name, last name, prefix, suffix, and all those details, titles, etc. So how would you represent that? You would break down this detailed segment into multiple elements: element 1, element 2, element 3, element 4, and element 5. So each element represents some detail associated with this detailed segment, right? So 1 might represent first name, 2 might represent last name, and 3 might represent middle name, right? So how are these elements delimited? So each element in a detailed segment is delimited using a asterisk symbol, okay, or star symbol, however you call it. So each detailed segment is delimited using a tilde symbol, and each element inside a segment is delimited using a asterisk symbol. You might have to group certain detailed segments together based on what they represent. For example, there might be a detailed segment that represents provider's name details, and there might be a detailed segment that represents provider's address details. There might be a detailed segment that might represent provider's contact information details. So you would group all of them together into a loop. Each detailed segment would constitute a couple of elements, and a couple of detailed segments put together would be grouped into a loop. So segment, element, and loop. Make sense?
Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes. From patient care to efficient administration, we cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.
Any EDI document is a hierarchical data file, and it is a multi-layered file also, and all the EDI documents, they would start with a ISA segment. So ISA stands for interchange start, and IEA stands for interchange end. Okay, so ISA represents the start of a hierarchical transaction file, and IEA represents end of the file. And inside one file, you can have data associated with multiple functional groups. Okay, and each functional group is represented using a group start, and it would be represented using a end of the data associated with that functional group is represented using a GE segment. And inside that, you have multiple transactions represented using segments, and it would segments associated with the transaction would start using ST, or it would be represented using ST segment, and it would end with SE segment, right? And anything in between can be represented, it would be representing a EDI transaction, for example, 837 transaction. Understood? And you can have more than one transaction segments inside a functional group, and you can have more than one functional groups inside a interchange file. Is it clear? This is a 837 transaction file. I hope you can see that. And as you can see here, your transaction file would start with a ISA and it would end with a IEA. And in this transaction file, we are, to simplify the example, we are only looking at one functional group, and it ends with GE segment. And inside this functional group, you have one transaction set, and it is represented using a ST, and the same transaction set would end with SE. Okay, understood? Here is where the group ends. That's what we were discussing so far, right? GE represents group end.
Okay.
Okay, and ST represents transaction set start, and SE represents transaction set end, and ISA represents interchange start or interchange control start, and IEA represents interchange control end. Make sense? So ISA and IEA represents the start and end of the files, transaction files, and GS and G represents, GS and G are used to encapsulate all the transactions that would be going to a functional group or one business partner, and multiple transaction sets associated with the same functional group are represented using individual ST and SE segments. Any transaction set, okay, or for example, think that you are a clearinghouse, okay, and as a clearinghouse, you might be sending EDI transactions to more than one insurance company. You might be sending it to Cigna, United Healthcare, Humana, Aetna, so Kaiser Permanente. So you might be dealing with multiple business partners. So all the transactions associated with one business partner would be enclosed inside a functional group. Okay, so anything in between GS and GE is associated with one functional group, and Again, let's go by example, thinking that this GS would represent Cigna, and to Cigna, you might be sending 10 837s and 5 835s or 278s, etc. So each one of those transaction or EDI transaction would be represented using a transaction set or functional segment, as we call it, and it would be represented by ST and SE. Anything between this ST and SC would represent one EDI transaction. Okay, so in this case, it is 837, as you can see. Again, like I mentioned in my earlier class, you don't have to remember everything, or you don't have to by heart everything. Okay, it's very easy to follow the pattern and understand what a transaction set would represent. And again, there would be documents called as companion guides and implementation guides that would help you in terms of understanding a EDI transaction. So you don't have to remember everything. Once you understand the pattern, okay, you would be able to use that guides to interpret each and every transaction. Okay, we will in this session and the next session, we'll try to understand how you would be able to easily interpret any EDI transaction. Okay, again, we don't have to get into much details of ISA and GS segments because our focus would be majorly related to the EDI transaction. So anything that is encapsulated between ST and SC segment, okay, is what we should be focusing more on. Okay, and that being said, here ST and SC segments are the transaction sets are represented using SC and SC segments, and ST would represent start or transaction set start, or it is also called as transaction set header. Okay, transaction set header. What is it called? It's called transaction set header. Okay, and SC is called as transaction set footer. Understood? Transaction set header and transaction set footer. So all the details associated with the 837 transaction, okay, for example, going by 837's case, if you remember from our previous session, we looked at that CMS 1500 and UB04 claim forms. We were discussing in our previous classes. We also discussed that the 837 transactions or 837 EDI transaction is or it would be 100% identical to all the information that you see inside a CMS 1500 physical claim form, right? So you should hold, or this document should hold all the information that we have seen on our physical documents, right? So every individual line inside this, every individual line in between this ST and SC segments, okay, each one of them represents information associated with a particular segment, or it would group all the data elements associated with some particular element group inside your claim file. Like one of that might be, one of that lines might be representing provider address, second line might be representing claim details, one other line might be representing membership information. Now let's get started. Okay, again, like I said, you don't have to mug up everything. You don't have to try to remember everything. Just try to follow through the pattern. And as we start looking into the examples, and as we start interpreting every single line or segment inside the 837 transaction, after a couple of segments, you would understand the pattern, and it is very, very easy to remember that. Okay, so let's start with transaction set header. Okay, so transaction set header starts with ST, and like we discussed earlier, every single line here, okay, is called as data segment, right?
Segment, yeah.
Okay, so this is one other segment, right? And every segment is further broken down into multiple elements. So each segment is delimited using a tilde symbol, right? And each element is delimited using a asterisk symbol. Okay. For example, like I mentioned, this line here, it might be representing submitter's information, right? So the whole line would represent submitter's information. And inside this, it might, each individual element might be representing individual data element associated with the submitter. Like, what is the name of submitter? ABC Clearinghouse. And what is the ID of submitter? 1, 2, 3, 4, 5, 6, 7, 8, 9, right? So that way, each data element is, each transaction set is grouped into a couple of segments. And each segment is further broken down into multiple data elements. Make sense? Okay, good. And again, a couple of segments are grouped together into loops also. Okay, we'll get into that a bit later. For example, if one line or one segment is representing provider's information or provider's demographic details, and the second segment is the segment beneath it is representing provider's address. Third segment is representing provider's contact information. All the three of them are associated with provider information, right? So they would be grouped together into a loop, okay, which is called as provider loop. Make sense? So your whole 837 or any other EDA transaction, transaction file is broken down into multiple segments, loops, and data elements. Okay, good. So now let's start with our ST segment, right? So ST segment, as I mentioned earlier, represents your transaction set header, okay, or transaction start. And the first element, okay, in next to the ST segment, okay, which we call it as ST01, okay. And again, when you read through it, we would call it 01, 02, and if there is any other element after that, we can call it as 03, right? So the first element inside the ST segment represents transaction set identifier. Okay, it would tell you what transaction you are dealing with in this case, right? So what does it say here? It says 837, right? So that means this transaction set you are looking at here is a 830, right? That means claim submission. Okay, and the next one is called as the next element inside that segment is called as transaction set control number. Okay, transaction set control number. Okay, it is, yeah. So it's a unique control number, okay, within that functional group. Okay, meaning, for example, think that like we discussed earlier. Okay, one functional group can have more than one transaction inside it, right? So you might have more than one 837 transactions inside the same functional group. So how would you differentiate one of those transaction, the 837 transactions with the other one? By using this control number, right? So again, mostly if you see 5010 here, it represents the version of our EDI transaction sets we are using, okay? Like we discussed earlier, there is 4010 and 5010. 5010 is the latest one, right? Okay. Understood? So, and after that, you have your number, okay? That represents the unique identifier associated with that transaction set. Is it clear so far? 01 element, okay, in your ST segment is called as transaction set identifier code. Okay, so remember there are multiple types of EDI transactions, right? One can be 837, there can be 835, there can be 278, there can be 267. There are multiple types of transactions, right? So here, when you see 835, it says that this is the identification associated with the transaction set, meaning you are sending a 837 transaction in this file, right? So, and again, we know that 837 represents claim. Okay, so if you see 835 there, that means that particular transaction set is a explanation of benefits or remittance advice transaction. It is the 02 element is called as transaction set control number. Okay, that means the unique identifier associated with that particular transaction set, right? So you can be sending more than one claims to Cigna, right? So if you are a clearinghouse, like we discussed earlier, you might be sending more than one claim to the same payer. So how would they uniquely differentiate each one of those claim transactions? So you should give a unique identifier for every single transaction set. Okay, so that way you are giving a unique identifier associated with that transaction set inside that functional group. After that, you have BHT. Okay, BHT represents beginning of a hierarchical transaction. Okay, so for now, let's leave it there. I'll come back to this. So it will make more sense when you understand the remaining segments before BHT transaction set. Okay, or BHT segment. Okay, so let's leave it there. Okay, and after that, you see NM1, right? Okay, NM1, anytime you see NM1, okay, by default, it represents a name segment, right?
Okay.
So NM1 represents name segment. Okay, but whose name is that? How would you understand whose name is that? Okay. You would be able to understand it by looking at the entity identity code or entity identifier code, which follows the NM1 segment, okay, or which is the first element inside NM1 segment. So this is entity identifier code, right? So it can be any entity's name, right? So there are multiple entities involved in a claim. There can be a insurance company, there can be a hospital, there can be a member, there can be a subscriber, there can be a billing provider, there can be a referring provider, right? There can be many people. So you might have to capture more than one entity's name. So how would you differentiate what the entity is, or how would you be able to understand whose name that is? By looking at the entity identifier code, right? Code. So in this case, 41 is the entity identifier code, and it represents submitter. So you don't have to remember it. Okay, don't try to memorize them because it's very tough and it's not needed. So when we look at the companion guides or the implementation guides, there you will see what entity type code or entity identity code represents what entity. Okay, so in this case, 41 represents submitter. Let me go back and explain it again. Okay, there are multiple entities involved inside a claim, right? So like I said, there can be a hospital, there can be a insurance company, there can be a subscriber, etc. Right? So to represent names associated with any one of those entities, you would be using the same segment, which is NM1 segment, right? So that's the reason, as you can see on this file, this is one NM1, which we have encircled here, and there is one other NM1 here, and there is one other NM1 here, right? So each one of those NM1s represent entity names, okay? But which entity name are you representing here is defined using this entity identifier code, right?
Okay.
So each entity has an identifier code. Submitter has 41. Provider might be having 46, right? Somebody else might be having 47. Make sense? Okay. So here 41 represents submitter. Okay. And again, after that, you have a single digit element, which is entity type qualifier, right? So what does it represent? It would represent, or it would take one of the two values. Okay, you will either see 1 or 2 for entity type qualifier. Okay, if you see 1, that means entity is a person or a human being. And if you see 2, that means entity is a non-person entity, right? Meaning a facility. That means an organization. That means a organization or a company or a facility, whatever you call it. So if you are representing a person, okay, like a member, okay, then you will see 1 as entity qualifier code, right? Because you are representing person. And if you are using an M1 segment to represent a non-person entity, which is an organization or a facility, then you would use 2 in this place. And in this case, what are we seeing? We are seeing 2, right? That means it's organization or a non-person entity. A person is submitting it, okay, you'll see 1 there. And if a organization is, if the submitter is organization, then you'll see 2. And in this example, it's an organization. Okay, and after that, it is followed by name of that entity. Okay, so in this case, what's the name? It's a clearinghouse that is submitting the claim. And what's the name of that clearinghouse? ABC Clearinghouse. Understood? So an M1 segment represents a entity name, and it 01 element inside the NM1 segment represents entity identifier code. And in this case, it is 41, and 41 represents submitter. So it's the name of the submitter. And is the name, is the submitter a person or a non-person, is represented using entity qualifier code. And in this case, the value for entity qualifier code is 2. That means it's a non-person entity or a facility. And what is the name of that person? ABC Clearinghouse, right? And if you see name of this entity, name of this entity is followed by a couple of blank elements, right? So you don't have any values between asterisks here. So they are nulls or they are empty. They are not provided. They are optional in this case. So why are they optional? So if it is a person entity, you may have first name, last name, middle name, prefix, and suffix, right? Prefix and suffix. So if it is a non-person entity, a facility would not have first name and last name, right? It would only have one name. So all the other elements are left blank. And after that, there are 2 elements towards the end of NM1 segment, right? So the first element or the last to second element here is called as identifier qualifier code, okay, or identification code qualifier. So what does that mean? So for any facility, when you submit the claim, if you remember inside our claim form, we have seen that for facilities or for any entity, there is a identifier code represented, right? So there are some places where it says put in your Medicare ID, or put in your Medicaid ID, or put in your NPI, or put in the doctor's NPI here, or put in the facility's tax identification number here, right? So the last element in your NM1 segment is identification code. So it would be the identification code associated with that particular entity. In this case, ABC Clearinghouse's identification code. And how would you know what type of identification code that is? So is that a social security number, or is that a Medicaid ID, or is that a Medicare ID, or is that a federal tax identification number, or is that a FEEN code, or is that a NPI? How would you know that? The 2-digit code which precedes your identification code is called as identification code qualifier. And in this case, it is 46, and 46 represents ETIN number. Okay, so tax identification number. Okay, so 46 says that tax identification number is being provided as the identification code for this entity, and the last element is your tax identification number of that entity. And in this case, obviously, we have given a dummy number, which is 1, 2, 3, 4, 5, 6, 7, 8, 9. Right?
Yes.
Understood? So let's take a quick look at it again. So NM1 segment represents entity segment, or it is called as entity segment, and or entity name segment. And the first element is your entity. What is that called? Entity identifier code, right? So entity identifier code is 41 here. So it would tell you what entity you are representing using this NM1 segment, and 41 represents submitter. And after that, you have entity type qualifier. So it would tell you whether the entity is a person entity or a non-person entity. And in this case, 2 represents non-person entity. And if you have seen 1 in place of 2, then it would represent a person entity. Right? And after that, you have either the organization name or person's last name. So in this case, it's a non-person entity. So obviously, it is the organization name. And after that, we have the couple of fields left as blank because they are optional fields, and they are needed only if it is a person entity. And in this case, it's a non-person entity. So you will not provide last name, prefix, sorry, first name, prefix, suffix, and middle name. So you have left all those elements as blank. After that, you have your identification code qualifier, which would tell you what type of identification code is being provided in this case. And finally, you have your identification code. And after that, you have PER segment. So PER segment represents contact information. Okay, and PER obviously represents person contact. Okay, but generally we would call it as contact information segment. So in this case, PER represents your contact information, and the 01 element in this case represents information contact, okay, or information contact qualifier. Okay, so IC represents information contact, and most of the cases you would only see IC, okay, because it's only information contact, meaning if you want to send any information, if you want to send a mail, or if you want to reach out to somebody regarding questions related to this particular claim, that is your information contact, right? And after that, you have name of the information contact, right? So what is the name of the information contact in this case? Wilma Flintstone, right? Wilma Flintstone is the person. Again, obviously, it's an example, okay? If somebody else is submitting, you would see their name in place of person contact name. Understood?
Yes.
And after that, you have your communication number qualifier. Okay, so anytime you see qualifier, it would tell you what type of qualification it is providing. So in this case, it is a communication qualifier. So that means it would tell you what type of contact you are providing, right? And in this case, TE represents you are providing a telephone number as contact for this person, right? So obviously you have your telephone number following that. Is it clear? Fine. So let's take a look at it one more time. What does PER represent? PER represents person contact information, and PER01 represents information contact, right? And IC obviously represents information contact. So it's information contact qualifier. And after that, at 02 element, you see name of the contact. And what's the name in this case? Wilma Flintstone. And after that, you'll see communication number qualifier. And you are seeing TE here. And TE represents telephone number. And after that, communication number follows, right? So we have a dummy telephone number here. Is it clear? So that's about person contact information. And obviously, the person contact belongs to submitter organization, right? So if you start interpreting the segments, you will understand that the first segment represented the submitter demographic information. It told you what is the name of the submitter facility, and it gave the identification details associated with the facility. And after that, you have contact information associated with that submitter, right? So who is the contact? Wilma Flintstone is the person contact, and there is Wilma Flintstone's telephone number, right? So as you can see, these two segments put together, they represent submitter information, right? So they belong to one single loop, okay? They are tied into one loop. So that loop is associated with submitter information, right? And after that, you see one other NM1 segment, right? So what does NM1 segment represent?
Name,
right? Entity name, right? So, and again, you should help me interpret this segment. So NM1 is representing entity information, and after that you have 40, and 40 represents receiver, okay, or payer in this case. In this case, insurance company is the facility or entity that receives the claim, right? So it is the receiver, and 40 represents entity identifier code, and in this case, value for that is 40, and 40 represents the receiver or payer. And after that, you have entity type qualifier, right? So it would tell you whether it is a person or a non-person entity, and who is the what is the value for that here? 2, right? So 2 is non-person entity, right? It's a facility, and after that, name of that facility follows. And what's the name of that facility? PCBSNC, Blue Cross Blue Shield, North Carolina. Right? And after that, we have a couple of elements that are left blank because it is a non-person entity. And if it was a person entity, we could have mentioned the person's first name, middle name, prefix, and suffix. And after that, you have identification code qualifier, right? So what is the identification code qualifier here? Again, it is 46, right? So what does 46 represent? ETIN number, okay? So yeah, so tax identification number. And after that, you have identification code. You have the identification code number represented here, and again we have dummied it to some default value, right? So 987, so it's all the numbers in reverse order. Believe me, by the end of this module, you will understand everything, okay? So let's keep practicing. We will keep going through each one of those segments, and we will take example of 835 again. It would look very similar, and we would go through the elements one more time to understand, or when we start looking at the companion guide. So that way you would get practice of it 3 times. Okay, and also I'll give you an assignment. Don't worry about it. Yeah, the last to second element, it's the identification qualifier code. It would tell you what type of identification you are providing. So each, so it can be a tax identification number, like in this case, 46 represents tax identification number. And there can be 78. 78 represents social security number. Itself. Yeah. So it would tell you what type of identification you are providing. And after that, you have the identification number. So in this case, 46 says that you are providing ETIN number, and 978, whatever it is the number, ETIN number. So if somebody is giving their social security number, you can see 78, for example. Okay. And the next element represents social security number of that person. Okay, good. So after that, the next loop here represents billing or pay to provider hierarchy level, right? So, so again, there can be more than one loops or more than one segments at the same hierarchical level, right? So you can have a billing provider and you can have a pay to provider also at the same level, right? So again, like we discussed in the beginning, EDI document is a hierarchical document, right? Or multi-level hierarchical document. So you can have more than one element at the same level. Like we discussed in our example, you can have two children associated with the same parent, and you can have two parents at the same level associated with the same grandparent. So same thing happens here. So when you are representing data here, you can have more than one provider associated with the same case, right? So for one claim, you can have more than one provider. Like we discussed earlier, there would be billing providers and referring providers. In this case, the HL segment represents hierarchical level. So you have more than one same type of elements at the same level. So you would say you would add a hierarchical level or HL element before providing that particular entity's details. So in this case, HL01 represents hierarchical level ID number. So if there are more than one billing providers or more than one pay to providers, you can have one HL element or hierarchical level element with identifier 1 and second one with identifier 2. But in this case, we only have one provider. So we are representing that with the identifier number 1. And after that, you have your hierarchical level code. Okay, so it would tell you if there is any parent associated with this hierarchical level. For example, there are two child elements and they need to be tagged to the same parent. So in that case, you would have a parent ID. But in this case, we don't have any parent ID. So we left that blank. And after that, you have hierarchical level code. So whether it is a information source or whether it is something else, usually it would be information source code. And most of the times, you would only see 20. Okay, for at least for the providers. Don't worry about the information source code. So it is a unique identifier again. Okay, and if it has any child elements associated with it, you will represent each one of those child elements as 1, 2, and 3. And if you don't have any child elements, you will leave it as 1. So again, this segment is not that important. So let's move on to our next segment, which represents the billing provider, right? So, and again, you will have a NM1 segment here, right? So what does NM1 represent? Entity. And what does 85 represent? 85 represents that it is a billing provider, right? So 85 represents billing provider because because 85 is the entity identification code associated with billing provider. So in that slot, we would put an 85 that says it's a billing provider. And after that, you have your entity type qualifier. And in this case, as you might have already noted, it is 1, which means it's a person, right? And after that, last name of that person would follow. Smith is her last name. And what is the first name? Elizabeth. So Elizabeth Smith is her name, right? Is the name of that provider. And is there a middle name? Yes, there is a middle name. So A is her middle name. And does she have a prefix like junior or senior, whatever it is? Okay. So if she has a prefix, sorry, yeah. So MD is her suffix, and she doesn't have any prefix here. And after that, you have identification code qualifier. And in this case, XX represents NPI, okay? Provider identifier. And what is her provider identifier? Again, we have dummied it. it's 0123457, whatever it is, it's the provider identifier. Okay, so I know it's too much information. Let's leave it at this. Okay, however, I want you to start writing it using a pen and paper, go through the recording again, and use the terms and terminology which we have used in the class, and go through this example which we are seeing, and define every single element we have seen. Okay, like tell me what is ISA, tell me what is GS, and what is ST, and what does NM1 represent, and what is every individual element inside that particular segment representing. I want you to write everything and take a screenshot of it, okay, or take a picture of it and upload it on the blog. Okay, should be handwritten again. Okay,
yeah.
So if you don't do that, most probably you will forget it after a couple of days.
All right, let's test your knowledge. Here's a question for you. Which of the following is a key consideration in healthcare data analysis? Option A, patient privacy and data security. Option B, maximizing social media engagement. Option C, optimizing for search engines. Option D, increasing website traffic. Take a moment to think, and when you're ready, choose the correct option. Remember, each choice holds a key to unlocking the answer. Good luck. Type the correct answer in the comments section. Hey there! Want to master Agile Business Analysis in healthcare? Our course is here for you. Learn at your own pace on our platform. In this course, you'll dive into Agile methods tailored for healthcare. It's like having a guide for improving processes, from patient care to efficient administration. We cover everything you need, from basic concepts to advanced strategies. It's created by experts who know the field. Your instructors are experienced pros who are ready to help and answer your questions. Don't just take our word for it. Our students find the course incredibly valuable. Others like you have found our training very helpful. The best part? It's very affordable. This chance to learn is within reach. Ready to become an Agile Business Analysis expert in healthcare? Sign up on our page now. For more details, visit our website.